Okay, we'll get started. It's very sparse here today. I think this is different than other years, but I want to thank everyone for coming. On behalf of my co-moderator, Nicole Jeffermans, I'm Lawrence Bussey. Thanks for being here in this important and interesting session on personalized medicine. Our first speaker is Alexander Zarbach from Germany, who is going to talk to us about acute renal failure.
Okay, thank you very much for the kind introduction. First of all, I would like to thank the organizers for inviting me. In the next couple of minutes, I will talk about acute kidney injury, and I will try to convince you that's not all the same. Next slide. Okay. So AKI is characterized by a sudden decrease of the GFR, and the incidence depends on the patient population and range between 2 and 50 patients per 1,000 individuals. AKI, even in mild forms, are associated with an increased hospital morbidity and mortality. This has shown in a couple of studies. As you all know, there is currently no specific therapy available. Therefore, management remains based on minimizing the risk of developing acute kidney injury. We cannot compare AKI with myocardial infarction because myocardial infarction is a disease with one specific pathophysiological mechanism. However, acute kidney injury is a syndrome that can be triggered by different causes like sepsis or ARDS. Therefore, the pathophysiology of AKI is very heterogeneous. You all know that we use the KDIGO criteria to diagnose and stage an AKI. The definition is based on changes of the serum creatinine and or urine output. However, this definition only don't address the molecular mechanism of the functional loss and only address the final common pathway of this syndrome, suggesting that we cannot use this definition for preventing acute kidney injury. In oncology, it has been shown for a couple of years that there are different subphenotypes of tumors and that these tumors respond differently to different therapies. And this has also been shown for ICU syndromes, for example, for ARDS, as shown in this study. Here, the authors identified 2 different phenotypes of ARDS, and the phenotype 2 is a pro-inflammatory phenotype which is characterized by high levels of different pro-inflammatory cytokines. And patients who developed this phenotype 2, this pro-inflammatory phenotype, had a worse outcome. They had less ventilator-free days and an increased mortality. And the authors nicely demonstrated that patients who develop a phenotype 2 ARDS benefit from higher PEEP levels. So if you apply a higher PEEP level in this patient population, the number of ventilator-free days goes up and the mortality goes down. But the PEEP level doesn't matter in patients who develop a phenotype 1 ARDS. AKI is comparable to ARDS, so we should consider different dimensions when we encounter a patient with AKI. The etiology matters because the etiology influences the pathophysiology of AKI and also affects the mortality. Another very important dimension is the duration of AKI. The pathophysiology of transient AKI is different from the pathophysiology of persistent AKI. 2 other very important dimensions are the molecular patterns and the trajectory of AKI, and I want to show you some examples. First of all, I will start with the etiology of AKI. So here on the left side, you see that patients who develop an AKI after cardiac surgery and fully recover from AKI have an increased risk of death, and they also have an increased risk to develop a chronic kidney disease. So the hazard ratio for death is 1.48, and the hazard ratio for CKD is 1.91. But this is completely different from sepsis-associated AKI, as you can see here on the right side. So in the upper figure, you see that the AKI severity determines the outcome. So patients who develop a severe AKI have a worse outcome compared to patients who only develop a mild AKI. However, patients who recovered from sepsis-induced or sepsis-associated AKI, partially or fully, had the same outcome like patients who developed a sepsis without an AKI. Only patients that didn't recover from AKI had a poor outcome, as you can see in this figure. But not only the etiology matters, also the trajectory of AKI matters, as shown in this retrospective analysis by John Callum and colleagues. Here, they looked at 46,000 critically ill patients. 17,000 patients had an AKI, and the authors demonstrated that 36%, 1/3 of all patients, had no early reversal, and 25% of all patients never recovered. 10% had a late reversal. However, on the other side, 2/3 of all patients had an early reversal. So they recovered from AKI within the first 7 days. Some patients had a relapse and recovered, and some patients had a relapse and didn't recover. So overall, 60% of all patients completely recovered from acute kidney injury at hospital discharge. And here you see that the trajectory of AKI matters. Here the authors looked for the long-term outcome, the 1-year mortality. And you see that patients who had an early sustained reversal or a late sustained reversal had a significantly better outcome compared to patients, for example, who never reversed. In addition to this, the authors nicely demonstrated that patients who had a suspected sepsis had an increased odds ratio for relapse, suggesting that the trajectory of AKI is influenced by the underlying disease. This study went one step forward and identified 2 subphenotypes of AKI based on different molecular signatures. So they looked at 1,200 patients, 800 in the discovery group and 400 in the replication group. And they measured different biomarkers and pro-inflammatory mediators in these patients. And based on the clinical variables, the pro-inflammatory mediator levels and the biomarker levels, they identified 2 subphenotypes of AKI. So the subphenotype 2 is the pro-inflammatory phenotype. Here, the biomarkers are upregulated, and in the other phenotypes, the same biomarkers are downregulated. And the most important biomarkers in this study are soluble TNF-alpha receptor 1, angiopoietin-2, and angiopoietin-1. And they demonstrated that the different subphenotypes influence this outcome, as you can see here. So patients who had a subphenotype 2, so the pro-inflammatory phenotype, had a reduced renal recovery rate and an increased mortality rate. And if you use the soluble TNF-alpha receptor 1 and the ratio of angiopoietin-2 to angiopoietin-2 to 1, you have a good predictive value to identify the subphenotype 2. All these data show that we should look at the different dimensions of AKI because the molecular mechanisms and the outcome is influenced by these. However, in daily practice, we cannot measure all the pro-inflammatory mediators which are required for the characterization of the different AKI phenotypes. So the question is, what does it mean for daily practice? It's correct that we cannot measure all the different pro-inflammatory mediators, but at least we can measure some AKI biomarkers, and these biomarkers give us some insight into the pathophysiology of AKI. This is a landmark study which was published almost 10 years ago by Michael Hase and colleagues. So they divided more than 2,000 patients into 4 groups based on the serum creatinine and the biomarker levels. In this case, they used NGAL as a biomarker. I want to focus on the 2 groups on the left side, so the 2 groups with a normal serum creatinine. Patient who had a normal serum creatinine and a normal biomarker level had a low dialysis and mortality rate. However, patients with a normal serum creatinine but an elevated biomarker level reflecting a kidney damage without a loss of function had a significantly increased dialysis and mortality rate, suggesting that a kidney damage without a loss of function impacts patients' outcome. So this is one biomarker. This is another biomarker, TIM2 and IGF-BP7, also known as NephroCheck. But obviously, this biomarker or these biomarkers cannot be used to identify a subclinical AKI as shown in this study. And here in this 2x2 table, you nicely see the relationship between kidney damage and kidney function. Kidney damage is shown on the x-axis and loss or function on the y-axis, and normally we are up in the upper left panel, and if there is a damage, we move to the upper right panel. So there is a damage and a normal function. And if we have a disease progression, there is a damage and a loss of function. And based on all these data, the Aki group proposed to include damage biomarkers into the definition of AKI, as you can see here in this figure. On the left side, you see the functional biomarker serum creatinine and urine output, and on the right side, you see the damage biomarkers. So there is one new stage, stage 1S, and this is actually subclinical AKI. You have normal functional biomarkers and elevated damage biomarkers, and all the other stages are divided into groups based on the biomarker and biomarker negative and biomarker positive stages. So in the last couple of years, we have performed a couple of studies trying to prevent or treat AKI in critically ill patients. And we always use the one-size-fits-all approach. Unfortunately, all the large trials were negative. And that's the reason why I think that we should switch from a one-size-fits-all approach to a personalized approach. And we can use different measures to achieve such a personalized medicine. So in critically ill patients, we have to deal with a very heterogeneous group of patients, and we have to break it down to a very homogeneous patient population so that we see some effects when we treat the patients. And here you see how we could stratify the different AKI phenotypes. We should look at the different causes of AKI, and we also should include the comorbidities of the patient. And then we should look for the different phenotypes, whether the patient has a transient or persistent AKI. We should also look for the urine production, and then, in addition to this, we should endophenotype the AKI. So we should measure different biomarkers because these biomarkers provide some pathophysiological insights. And then we should decide whether we want to treat the patients with a therapy A or B. And we tried such a personalized approach. Here in this observational study, we included 200 patients undergoing cardiac surgery, and we demonstrated that patients who have a hyperinemia after cardiac surgery had an increased risk to develop an AKI and an increased risk to develop a cardiovascular instability, as you can see here in this table. And we were lucky. We had access to a compassionate use program where we had the possibility to use angiotensin II, and we proposed, based on this observational study, that we have an angiotensin II deficiency after cardiac surgery. So if angiotensin II goes down, the body tries to compensate for this and increases the renin levels. So in this trial, our hypothesis was the use of angiotensin II in cardiac surgery patients with a hyperreninемia reduces renin levels. So we measured renin in all patients undergoing cardiac surgery, and in patients who had a high renin level and were on vasopressors, we treated them either with norepinephrine or with angiotensin II. And the outcome was the renin levels. And here you can see that if you treat these patients with a hyperreninemia with norepinephrine, the renin levels further increase, whereas if you treat these patients with angiotensin II and you compensate for the deficiency, the renin levels go down. So my conclusions are AKI is a common problem in hospitalized patients, especially in critically ill patients. AKI is a syndrome that can be induced by different causes, and we have to consider this when we want to prevent or treat acute kidney injury. Different AKI phenotypes exist, showing that the activation of different signaling pathways may cause a renal functional impairment. And based on the different subphenotypes of AKI, an individualized approach has to be implemented in the treatment of patients with acute kidney injury. Thank you very much for your attention.
Wow, thanks a lot for being the very first speaker on this session. I think there's time for some questions, if there are any, from the audience. There's one from me. Very interesting that you're adding these biomarkers to this new definition. So what would be your idea about how would this inform the clinical practice?
So, as I said in the beginning, so when we start treating or preventing acute kidney injury, once the functional biomarkers, serum creatinine and urine output increases, at this moment we already have a decrease of the GFR by at least 50%. So that's too late to prevent acute kidney injury. And that's the reason why the biomarkers help to prevent acute kidney injury. So if we use the biomarkers to predict the development of AKI, we can start with a therapy earlier, so we can try to prevent acute kidney injury. And we have shown this in a couple of studies, that the implementation of the KDIGO bundle at this early stage can prevent the development of AKI after cardiac surgery. And also other people showed this in other patient populations.
Okay. That sounds really helpful. Thanks a lot, Dr. Zarbach. Okay. We move on to the next speaker. I'd like to introduce Dr. Stéphane Gaudry, who will also speak about renal replacement therapy and will tell us for how long we should do it.
Thank you. Okay. Dear colleagues, dear moderators, I'm very happy to be here in Brussels after 18 months in Paris. My name is Stéphane Gaudry. I work in ISICEM Hospital, and I am an intensivist. Okay. I have no conflict of interest regarding acute kidney injury or renal replacement therapy. However, the Aki trials were funded by a grant from French Ministry of Health. In 2012, KDIGO guidelines state that absolute indications to start renal replacement therapy were life-threatening complications. 3 complications: refractory severe hyperkalemia, refractory severe metabolic acidosis, and pulmonary edema resistant to diuretics. So the first message is that patients with this kind of complication are not the right candidates for the wait and watch approach. So what is exactly the wait and watch approach? It could be defined as postponed renal replacement therapy in critically ill patients with severe AKI who have no life-threatening complication. Last year, we published this systematic review and individual patient data meta-analysis of a randomized control trial in the Lancet. And it was the occasion to have individual patient data from 9 randomized control trial, and it was quite good because we identified 10 eligible randomized control trial. And as you can see, we include Aki, of course, Ideal ICU, Heroics, Elaine trial by Alexander Zarbach, and the pilot study of Start AKI. We analyzed almost 1,900 patients, and the result is that mortality after 28 days did not differ between the two groups. However, 42% of patients in the delayed group never received renal replacement therapy. About the secondary outcome, the mortality at different points, the duration of hospital stays, the renal replacement therapy dependence at hospital discharge, the mechanical ventilator free day or vasopressor free day, and rate of adverse event did not significantly differ in this study. And even in the subgroup analysis, because we have some interesting subgroup with patients with sepsis or severely ill patients according to SOFA score higher than 12, you can see that it is the same result. There is no subpopulation where there is a difference. Few months after this publication, the Start AKI trial was published in the New England of Medicine, and I would like to pay tribute to Ronwald and Schudbach because it was an amazing trial, an international multi-center randomized control trial including 15 countries and including almost 3,000 patients in ICU with severe AKI. They compare an accelerated approach, which is the early strategy, and a conservative strategy for renal replacement therapy initiation. And the result of the primary outcome is that there is no significant difference between the accelerated approach and the standard approach when you look at the mortality after 90 days. So when you had Start AKI and the systematic review and meta-analysis, you have almost 5,000 patients. So you can conclude with a high level of evidence that in the context of severe AKI and in the absence of life-threatening complication, delaying renal replacement therapy should be recommended. Okay, but there are some difference, some heterogeneity in the delayed strategy approach. You can see in Aki trial that the waiting time, so the time between the randomization and the renal replacement therapy initiation, was 57 hours. It was 31 hours in Start AKI, 20 hours in Elaine, and 44 in Ideal ICU. You can also see that there is a difference according to the percentage of patients who never receive renal replacement therapy in the delayed group. 38% in Start AKI and 50% in Aki trial. So the more you wait, the less you start renal replacement therapy. And reducing renal replacement therapy use may be helpful for two reasons. This is my opinion. First, reducing the risk of artificial kidney-induced kidney injury. I will show you what is exactly this new concept. And reducing the risk of shortage of renal replacement therapy during a sanitary crisis like COVID-19. So what is the artificial kidney-induced kidney injury? In Aki, we showed that patients in the delayed group had more rapid renal function recovery if we approximate renal recovery as adequate urine output with no need for renal replacement therapy. It was the first result, and it was just the emergence of a new concept. But we published this secondary analysis of Aki, and here you can see that the cumulative urine output during the first 2 days after randomization is significantly different between the two strategies, with a higher cumulative urine output in the delayed group compared to the early group. And this difference is independently associated with renal function recovery after ICU discharge. Moreover, if you focus on the ultrafiltration, there is also a difference, but here there is more ultrafiltration in the early group compared to the delayed group. And if we had ultrafiltration and urine output during the first 2 days after randomization, there is no difference. But there is a difference. In the delayed group, this is a kidney who does the job. In the early group, this is a machine. So it was the emergence of this concept of artificial kidney, induced kidney injury, and permissive hyperuremia. And interestingly, this concept was confirmed in START AKI trial, because in a secondary outcome, you can see that in this trial that patients in the early group are more frequently dependent from renal replacement therapy after 90 days. This is very, very important. Why? Because 90 days, this is the limit between the acute renal failure and the chronic kidney disease. So maybe these results show that early renal replacement therapy is associated with chronic kidney disease. So the second reason and hypothesis is that it could reduce the risk of shortage. You know now that we had some problem, and for example, this colleague in New York, they had to use acute peritoneal dialysis because of RRT device shortage. So when you look at this difference in the weighting strategy, you can see that there is an heterogeneity. But we had a question a few years ago. It was how many times we can wait, for how long the wait and watch strategy, because probably there is a limit. This is the reason why we conduct this second trial, the Aki 2 trial. And just a rapid reminder, in the delayed group of Aki 1 trial, the pre-specified criteria to start renal replacement therapy were, of course, the 3 life-threatening complications: severe hyperkalemia, severe metabolic acidosis, and acute pulmonary edema due to fluid overload and resistant to diuretic. But we also had 2 other criteria: oligoanuria for more than 3 days, and serum urea concentration greater than 40 millimole per liters. This is not, it was our opinion. We thought that 3 days it was so not too bad, and probably it was a safety criteria. But it was not an urgent indication to start. So this is why we conduct this study in Aki 2. Patient with AKI stage 3 of CADIGO with mechanical ventilation and or catecholamine infusion were observed in an observational stage. And in this observational stage, we applied a delayed strategy. And if patients reach criteria, which the 2 last criteria, serum urea concentration greater than 40 millimole per liter or oligoanuria for more than 3 days, patients were randomized in a delayed RRT strategy, which was exactly the same strategy than in Aki 1, and a more delayed strategy. And in this strategy, patients receive RRT if they reach urea concentration greater than 50 millimole per liter. And in the delayed strategy, patients receive RRT as soon as possible. We include almost 800 patients in the observational stage, and we finally randomize 278 patients. The characteristics of the patients are very similar to Aki 1, so we can discuss the difference between different RCT, but we choose to have the same patients than in Aki 1. It's patients with a high proportion of septic shock and ARDS, as you can see. The primary outcome was the number of RRT-free days. This kind of outcome is a kind of composite outcome because the mortality is important and the exposition to RRT is important. And you can see that there was no difference when you look at the median number of RRT-free days between the 2 strategies. So this is a negative trial. However, in the more delayed group, 21% of patients never receive renal replacement therapy, and the time difference between the delayed strategy and the more delayed strategy was 30 hours. When we look at the mortality outcomes, you can see that at day 60, there is no significant difference. However, the mortality in the delayed group was 44%, and in the more delay, it was 55%. Hopefully, we pre-specified a multivariate analysis, and in this pre-specified multivariate analysis, the more delayed strategy was associated with increased risk of death. So to summarize the result of Aki 2 trial, the wait-and-see approach could be good, but not too long, and probably after 2 or 3 days of oligoanuria, we should start renal replacement therapy, even in the absence of life-threatening complication. So this is my last slide. This is to summarize. Probably we can discuss this slide after. In the context of severe AKI, Caligo 2 or Caligo 3, in a critically ill patient in a context of multi-organ failure, the first question is my patient have severe complication, hyperkalemia, severe metabolic acidosis, or pulmonary edema due to fluid overload? If yes, it's possible to try a medical treatment, but in context of refractory complication, you should start urgently renal replacement therapy. But in the absence of this kind of complication, Aki, Start AKI, IDEAL ICU show that there is no urgent indication to start renal replacement therapy. We can wait. However, after 2 or 3 days, I think we should start renal replacement therapy, even in the absence of life-threatening complication. For the limit of urea, I have no idea, but probably 40 millimole per liter should be a limit. Maybe it's 45 for someone, or 50. I think we have to look at the patients, and if the urine output increase progressively, maybe we can wait the renal function recovery. Thank you very much.
Thank you, Dr. Godry. Do we have time for one question? Well, I have one. So Start AKI and Aki and your meta-analysis included thousands of patients. And so I think there were some very nice generalizations that you were able to draw regarding the delay of RRT. As we sort of shift toward personalized medicine, are there subpopulations where you think that we should be using early RRT?
Yeah, this is the question of the session, but it's very difficult to answer this question. At this time, the very hot topic question is how to manage fluid overload and what is the good timing for renal replacement therapy to manage fluid overload in our ICU. We don't know, but probably we need more data on this kind of patients with high fluid overload, but no urgent indication to start renal replacement therapy. In this kind of patients, maybe we should start early. In the Elaine trial by Alexander, you can see that there is a majority of patients with fluid overload and pulmonary edema, and this is the trial which show that the early strategy is better than the delayed strategy. This is the only trial to show that. So probably in this kind of patients, it's important to start early. For the others, we have no biomarker, and even if we have a biomarker, is it really useful? For example, I can ask a question. If you have a biomarker for your COVID-19 patient in emergency department, which show you that there is 90% probability that he will be intubated in 2 days, you will start invasive mechanical ventilation in the emergency department? No, you will wait 2 days. So for the biomarker, maybe you have something to say, Alexander.
Thank you very much for this excellent talk. So that was my question. If you would have a biomarker or a test that can predict that this patient will definitely require a renal replacement therapy, when would you start? You've already answered this question, but I would like to give some more data in your postdoc analysis of your Aki trial in the supplementary. You showed that if you only look at the patient who really required renal replacement therapy, the mortality in the late group was significantly higher compared to the early group. It was similar to our data. But at the moment, we cannot really say which patient really requires renal replacement therapy at a later stage. So, and if I ask you now, you would have a test in your hand which definitely tells you that this patient requires renal replacement therapy. Would you start early or late?
I will answer in 2 times. Sorry. First, the comparison between patients who finally need renal replacement therapy in the delayed group with the whole group with the whole early group is not possible. You know very well that. This is why START-AKI did not do this kind of analysis, because there is a lot of bias and it's impossible to compare this kind of patient. However, we have write a paper with Paul Palewski on this question in critical care. The second question is, okay, if I'm sure that these patients will need renal replacement therapy, personally, I prefer to start after 1 or 2 days, because during the first 1 or 2 days in critical ill patient, you have a lot of other things to manage, catecholamine, ventilation, and I prefer to start when the catecholamine go down. But I'm not sure. But we will have some data on this question, because we have a biobank from Aki 2, and we will test some biomarker and analyze if it's changed something.
Thank you very much.
Thank you.
Let's move on. And I will invite the speakers to please feel free to take off your mask while you're speaking. I'd like to introduce Dr. Viad Baron, who will talk to us about cardiovascular.
Okay, thank you very much.
Sorry if I butchered the name there.
You prefer I keep my mask? No, that's okay.
It's your choice.
Okay. So good morning, everyone. Very happy to be there, and fortunately to have some real people in front of me. This is much better than to be behind his computer to speak through Zoom session. So really happy once again. So a different issue now about the cardiovascular phenotypes in septic shock. And just to tell you that I do not have any conflict of interest for this lecture. So I would like to start by this slide, which is finally, it was published in 1981, a very, very old study. And it was our understanding of the cardiovascular phenotype and the timeline before intensivists became to perform echo in the ICU. And it was very classical that before the resuscitation, we had a low flow state because the patient was severely hypovolemic. After the initial resuscitation and fluid optimization, we have the classical warm shock with the hyperdynamic state, vasoplegia and high cardiac output requiring norepinephrine infusion. And it was only at the very end stage of the process that patients develop cardiac failure, multiple organ failure, and finally death. And this is something that probably the echo adds to the understanding of the hemodynamics in the septic shock patients. That this is much more complicated than this usual timeline, and many mechanisms are completely intricated even very early during the septic process. I show you this paper that we did in a little bit less than 200 septic shock patients, in whom we perform an echo during the first day after the initial resuscitation regarding fluid optimization. You have the relationship between the ejection fraction and the cardiac index, and this is just interesting because you can split the patient grossly in 4 categories. One, where the ejection fraction is low and the cardiac index is low, and even you are during the first day, there is some left ventricular systolic dysfunction. Another subgroup where the ejection fraction is low, the cardiac index is still maintained. So finally, you have LV systolic dysfunction with some adaptation due to tachycardia, for instance, or preload adaptation. Another subgroup where the ejection fraction is normal and the cardiac index is high, probably the patient is still vasoplegic with some hyperkinesia of the LV. And finally, the last subgroup is a patient with normal LV systolic function but a low cardiac index, and the patient could be still hypovolemic or probably could have RV failure, and you have to look at the RV function. So look at if you do the echo, for instance, you have this kind of phenotype. So the LV here, the RV here. There is some LV systolic dysfunction. Look at here the short axis view of the LV. You have a very poor contractility of the left ventricle, and this is just a pulsed Doppler at the mitral valve, reflecting that the LV filling pressure is not elevated. You may have this phenotype, completely different. This is the RV and the right atrium. You have a failure of the right heart. This is especially visualized in patients with septic shock and ventilated for acute respiratory distress syndrome. You can have this phenotype. This is a parameter that we usually use, which is the collapsibility of the supravena cava, a good reflect of the amount of blood you have into the thorax. And when you have this kind of collapse, probably the patient is still hypovolemic. And you can see that in this situation, the LV systolic function is, of course, preserved. And finally, you have this last phenotype, which is a very hyperkinetic LV, just reflecting probably the fact that the vascular motor, the vascular tone is depressed, still depressed, with a low blood pressure and the low LV afterload. So what about, very briefly, about the specificity of LV systolic dysfunction? First of all, this is the landmark study from Margaret Parker, just to remind you that whatever the LV systolic function, finally the LV filling pressure is not elevated, or at least below in every case 18 millimeters of mercury. And it was also reported a few years later in this paper in patients with or without LV systolic function. You see that the wedge pressure was not different between the two groups. Sorry. Here, that's interesting also. Another understanding that we need to have, by definition, LV systolic function is a combination of intrinsic contractility of the LV and LV afterload. Here on the x-axis, you have the maximal elastance, which is a surrogate of the intrinsic contractility of the LV, and here you have the ejection fraction. Look at, for instance, we know that in all patients with septic shock, the intrinsic contractility of the LV is depressed. But if you do the echo, or if you evaluate the LV systolic function, when the blood pressure is still low, and so the afterload is low, you will observe a normal LV systolic function. While now, if you evaluate the LV systolic function after normalizing the blood pressure, you unmask the LV systolic function and the depression in the intrinsic contractility. And this is why, if you look at the literature and different papers, you have very different incidences of LV systolic dysfunction, but very well associated with the time you evaluate the function. If you evaluate the LV systolic function very early, after 6 hours following the admission, the incidence is low. If you look at after 12 hours, the incidence is higher. The first day, higher, and the first 3 days, much higher. So it means that here, probably most of patients have a normalized LV afterload, and so you unmask the LV systolic dysfunction. For instance, look at here. This is the echo before norepinephrine infusion. The blood pressure is still low, and so the LV systolic function is normal. We infuse norepinephrine because the blood pressure was low, and we recheck the LV function after norepinephrine infusion and blood pressure normalization. And you can see some completely different LV systolic function compared to before the norepinephrine infusion. This is something very important because if you look at, of course, this kind of LV systolic dysfunction, you may decide to infuse, for instance, small dose of the butamine, allowing you to increase the cardiac index and to improve the LV systolic function. Just look at the heart rate if you are right, the heart rate did not increase, and either you have a trend to decrease because you improve the LV systolic function. What about the specificities of RV injury? I just can summarize the fact that there is a lack of consensual definition what is RV injury in patients with septic shock. Let's say briefly you have two approaches. This one, which is more focused on RV failure and defining RV failure as a congestive status with RV dilatation, acute kidney injury due to congestion. And you have this other approach, more cardiological, which is just to look at parameter of RV systolic function, and here to look at that these parameters are decreased. Whatever the definition, and this is something very important for clinical practice, you have to keep in mind that if you have RV systolic dysfunction or RV failure in patient with septic shock, it is very likely that patient is unresponsive to fluids, and even it could be deleterious to give more fluids. I just look at this paper. Just here you have the size of the RV on the x-axis and the pulse pressure variation on the y-axis. Just look at this patient, in green, the patient is very unlikely to respond to fluids. In orange, the patient is very likely to respond to fluids. So it's a little bit difficult figure to understand. But look at here in the right and upper corner, you have dilatation of the RV. And despite the fact that the pulse pressure variation was very elevated, the patients were very unlikely to respond to fluids. They had RV failure. So for all these reasons, we really need a better characterization to personalize the treatment and the hemodynamic management we apply in our patients. And they could be explained the fact that if we don't do that, if you look at the trials, most of the trials, they are negative. You have this systematic review about the goal-directed therapy. This is not the only reason why these studies are negative, but this is one of the reasons because you apply the same treatment to everyone, while, as I show you, there is a huge heterogeneity in the hemodynamic profile. I like this study because it's a good illustration what you have done to do. You can do that to publish in the New England Journal of Medicine, but don't do that to manage your patient. You take a huge series of patients with sepsis, and you randomize patients with levosimendan, which is an inodilator, versus no levosimendan infusion. And you look at, first, the primary outcome, which was the change in the SOFA score. It was negative. And second, the secondary outcome, which was the in-ICU mortality, which was also negative. And so this study was negative because you had patients probably who had a very deleterious effect of levosimendan on one side, and other patients probably who benefited from the levosimendan on the other side. And so at the end, this is neutral. But you don't know what happens in the black box because there was absolutely no characterization of patient before randomization. I prefer this kind of study published in a much lower impact factor journal, Critical Care Medicine, but I don't want to support the use of VA ECMO. It's just an illustration to give you that providing the fact that you very well characterize patient, here very low ejection fraction, very high catecholamine dose, high lactate level, very low cardiac index, the authors propose to manage the patient using the VA ECMO, and they suggest in this very preliminary study that it could be beneficial in this very specific subgroup of patients with very severe LV systolic dysfunction. Fluids management, of course, is key, and you need to better characterize patients before deciding to give or not to give more fluids. I just show you this slide from the Andromeda shock. And you have here the rate of responders and non-responders to fluid according to the hours following the randomization in the study. And this is very nice. It very nice illustrates the fact that it is very well balanced between responders and non-responders. But look at after 4 hours, only a few patients were still responders. So before giving more fluids, look at exactly the hemodynamic profile. And especially, as you know now, this is an old study because we know that the fluid overload is highly associated with a worse outcome in this patient. So one approach could be what we call the clustering approach, which is finally to put in the computer, sorry, it's very too small, but you think in the computer very different hemodynamic variables and clinical variables, because you have the hypothesis that this is the key variables of interest, and you ask the computer to classify the patients according to different phenotypes or different clusters. And so once you have validated your clusters with a quite complex approach with internal validation and external validation, you have a better characterization of your hemodynamic profile, for instance, in septic shock patient. And the clinical application is very obvious. First, you improve the management probably, but second, for to design the trials, you can apply a better design based on the clustering and the characterization of your patient. And this is especially what we tried to did in this study. It was a very preliminary report because the cohort was not so high to put into the machine so many variables. But you see that we put in the machine many echo parameters that we thought it was the key parameters regarding the LV systolic function, fluid management, the cardiac index, but we had also clinical parameters, the blood pressure, the heart rate, the dose of norepinephrine. Just to show you, this is what the machine gave us. So it's a little bit complicated to read, but each color is a different clustering, a cluster or a different phenotype. And just I summarize in blue, we decided it was finally well-resuscitated patient, 17%. In red, it was LV systolic dysfunction phenotype, low ejection fraction, low aortic VTI, 18%. In yellow, it was hyperkinetic LV, so probably still vasoplegic patients, 23%. In purple, it was RV failure associated, it's interesting, with low diastolic arterial pressure. And in green, 19%, it was a still hypovolemic patient. So could be an approach difficult to apply at the bedside, but just for designing trial could be interesting. I skip this slide, not so interesting. And I want to conclude. So even in the early phase of septic shock, different cardiovascular phenotypes may support the circulatory failure. LV systolic dysfunction, RV failure, hypovolemia, vasoplegia with a hyperkinetic left ventricle. A better characterization is required for management and also clinical research because one does not fit all, and echo is very suitable to this better characterization. So combining echo parameters with clinical parameters may allow us to better determine these cardiovascular phenotypes, but further studies should use larger cohort to include much more parameters than we did, clinical, hemodynamics, and echocardiographic parameters. Thank you for your attention.
Thank you for your excellent plea to include much more parameters than we do. You're not making clinical practice easier for us.
It's not very difficult, the echo.
No, the echo not, but the interpretation, yeah. I've been told we are a little bit lagging behind, so I'm very sorry that we don't have any time for further questions, Dr. Baron. Thank you. I'd like to move on and introduce the next speaker, which is Dr. Rischmeier, who will tell us about personalized nutrition in ICU.
I'm going to get connected here. Thank you. Okay. So, as our other speakers have, I'll discuss the key role of personalizing ICU nutrition and new tools and new opportunities we have to do that for our patients. Because, of course, the key message of all of our lectures is we need to take the responsibility not only for what happens to our patients in the ICU and the clinical management we do in the ICU, but also what happens after the ICU. And clearly nutrition is one of those key care pathways that affect not only outcome in the ICU, but especially outcome after the ICU. With our ultimate goal being to create survivors of our patients to go back to families and go back to a life worth living and not victims, patients that perhaps will never return to a life at home with their families. So that ultimately patients can walk down the street with the people they love again and hold their grandchildren and their children again. And so again, personalizing all of our care is challenging in these patients. COVID-19 is ravaging the United States again, as those of you that may be from there know. And this is very challenging to personalize any of our care in such a challenged environment. But we can do better, and we've learned that from our previous speakers, and I believe we can do better in nutrition and metabolism as well. But how? Well, clearly all the speakers have said the same thing, but I would agree. One size does not fit all, and it's true in nutrition as well. We need to personalize nutrition therapy with the right dose in the right patient at the right time, and for the first time, we need to measure what we're doing in nutrition. I think we have been behind for a very long time. Lord Kelvin said it well, if you can't measure it, you can't make it better. And I think we often in nutrition have lagged behind. We wouldn't give vasopressors without measuring the blood pressure. I'm going to advocate to you that we shouldn't give nutrition without measuring our patient's caloric needs and the effect on the patient. And we have lots of opportunities to do this. It's a summary of what I'll briefly cover, but these are many opportunities we have now that we perhaps didn't even have 2 years ago. So first, do we know who the most malnourished patients are? Or how best to monitor what our nutrition is doing? Is it being absorbed? Is it being taken up by muscle and other cells? And do we have better tools? Well, I think we start with how do we tell who the best and worst nutrition status patients are? Is this patient at greater risk coming from a large operation to your ICU, or is this obese patient at lower or higher risk of mortality and complications? I think we obviously often think the obese patient is, but our data would say otherwise. We know the best survival from practically any disease you can be stricken with, acute or chronic, is to have a BMI around 30 to 31. So I think there's many of you in the audience need to gain some weight if you're going to be hit by a bus or hit by the COVID or something else. And that's true in critical care as well. It's not as clear in COVID-19, but in ARDS, we know that the mortality from ARDS decreases linearly as BMI increases, all the way out to 40 perhaps and beyond. And that's true in critical illness as well, where we also know that lower BMIs have a much higher mortality than high BMIs. And again, we need to start focusing our trials in nutrition on these higher risk patients, which we have not done to this point. We haven't had good ways to measure it. And in terms of ICU recovery, for every 1 point decrease your BMI has, or conversely, every 1 point increase your BMI has, you have a 7% greater chance of recovering meaningful functional quality of life. So again, a patient with a low BMI is much more likely to have complications and much less likely to recover quality of life. And this can be an enormous difference from a BMI of 30 to a BMI of 22. So again, that person running in front of you can't believe weighs 50 pounds more than you and was beating you in that race. There may be a reason for that. They may be more fit than they appear. And what makes someone fit to survive critical illness or other stresses? And do we have new tools to assess? And one point, obviously, is it's not just the BMI, but it's the muscle mass. So clearly, we need better ways to assess muscle mass, and CT scan has been our first and most useful way to do that initially. And we know from research from across the globe that lower muscle masses at ICU admission increase mortality. So coming into the ICU with a lower muscle mass clearly increases risk of mortality. And this has been true in the elderly and the young. So this was a study of elderly trauma patients. Average age of almost 80. They were driving, otherwise healthy trauma patients. 71% of them, free-living elderly patients, were sarcopenic when they underwent their traumatic injury. And the reality was you couldn't look at them and tell who sarcopenic patients were. The thin patients were sarcopenic, the obese patients were as well, and the normal weight patients were as well. You couldn't tell the difference. You need to measure. But the reality was the mortality was doubled in patients who were admitted with sarcopenia versus those that weren't, controlling for other factors. So it associates with outcome. So do we have better tools to assess? And if so, how can we do that? Well, first, how to measure muscle mass. I think clearly we've got CT and other surrogate measures, but now we also have ultrasound. And the ultrasound could be quite useful for our patients, and anyone can do it. We have ultrasounds to put central lines in. We have them at every bedside throughout the world in our ICUs. And we've been able to show reproducible results from many different specialties, dietitians, nurses, physicians, research associates. But can we take the ultrasound to the next level for muscle? And can we learn from what our Tour de France and elite athletes do on the race course? They use ultrasound for the muscle as well every day. In fact, these are some of the folks we work with, ultrasounding Tour de France athletes, to learn more about their nutrition and metabolism. So there's a muscle-specific ultrasound that can take a gray picture like this and color it like this, almost like a muscle biopsy, and it measures muscle glycogen, and it's validated against muscle biopsy. The dark purple being areas of high glycogen, light purple being areas of low glycogen. It's a simple toy. It plugs in, it's about this big, plugs into your iPhone, like an small ultrasound probe, and can give you results in minutes. It even tells you where to put the probe on the muscle and if you have a good image. It's incredibly simple to use and can be used in just a few minutes. As you can see here, very simple, measuring leg muscle. We measure temporalis for fast and slow twitch, and also the chest. So again, what does muscle glycogen tell us? Well, we know that patients who have higher muscle glycogens perform better. And when your muscle glycogen drops, your ability to perform exercise is worse. It also leads to muscle damage. If your muscle glycogen is very low, as I will show you in critical illness it is, your muscle can't be anabolic, and it has to break down amino acids in your muscle to get fuel. And so again, this cannot be anabolic and cannot recover. So what happens to muscle glycogen levels in the ICU? This is what a Tour de France athlete looks like before competition. This is what the average person looks like with a score of 65. It scored 0 to 90. So this is what we've looked at groups of patients scoring. This is the average in an athlete, sedentary, post a Tour de France phase, post a marathon, 26 miles. This is critical illness. It's like running 5 marathons. It's devastating to the muscle after just 48 hours. This is what their muscle looks like. Water follows glycogen. That's why the athlete has got a very dark muscle, very, very white muscle in the critically ill patient, and this is common. We've colored it now. You can see different diseases have different appearances as well over time. Neurotrauma seems different than sepsis, and you can see other things as well. 70% of our ICU patients had 0 glycogen at the time that we saw them, and it puts the muscle at great risk. We can also watch it recover and see nutrition and nutrients being taken up by the muscle. So these are patients who are able to recover muscle as they move along. And this is a signal for the end of the acute phase. And it's not just the muscle mass, it's the muscle quality. Again, poor muscle quality or intermuscular fat predicts outcome as well. And we know that measuring intermuscular fat is just as important as measuring the size of the muscle. And so again, we can do that with this device. It's called the Imet Eye Index. We've developed it at Duke, and you can actually have the ultrasound trace out the fat versus the muscle areas of the muscle. And we found in ICU patients versus athletes that the muscle fat is much, much higher. The numbers getting bigger means higher. So again, we saw this was significantly increasing, and what this shows is, like Dr. Puducherry showed us, Sudin showed us, the muscle can't use lipid when it's stressed, and it begins to accumulate within the muscle tissue. What about another device, the BIA? The BIA is a simple muscle device, body composition device, that clips to your fingers and your toes and measures in 5 minutes. Arthur Van Zanten has written a beautiful, the best I've ever seen, review in our recent issue in Current Opinion in Critical Care. If you want to learn more about it, it's got a lot of promise, especially the phase angle, perhaps in COVID-19 and other diseases, for prediction. This was just a paper that came out a few months ago, shows that low phase angle patients in COVID, other things being controlled, are very predictive of mortality. And so this is a very quick and easy measure that can tell us a lot of information. What does the data look like from a BIA? It looks like this. So you can see this particular patient has a very low muscle mass content and a very high body fat, very cachectic, very sarcopenic. This was a recovering ICU patient in our ICU after being in the ICU for about 2 weeks. And in fact, we can combine modalities. This is his same ultrasound from that patient. You can see the very small amount of muscle and the very large amount of fat as the patient can't use substrate. Finally, how much to feed in critical illness? We need objective measurements to guide us, especially in COVID-19, as I'll show you. This is a very unique disease state metabolically when we make measurements. All our guidelines say we should be using metabolic cart, but it's been challenging to do. And our data would even say, and our guidelines would even say, we should be using it in COVID-19, because it can be done, and I'm going to show you that. Because we have data from our meta-analyses that show that using indirect calometry can actually lead to better outcomes if we're not overfeeding and underfeeding our patients. When you look at the data, it seems to show there's a trend towards improved survival if we're targeting and personalizing our nutrition delivery. But our challenge has been we've never had good metabolic carts. They weren't very accurate, they were hard to use, they were hard to calibrate, they were very big. That's not true anymore. A group of us from around the world, led by Claude Bouchard and others, Meta Berger, names you know, got together to work with industry to make a better metabolic cart. And we hope we did, and it's available now to you. It warms up in minutes. It self-calibrates. It's very small. It's very accurate. It's calibrated against mass spec. And we hope we've addressed all the challenges. I've been using it for 2 years now, and it really is an impressive device. We were getting ready to study it in ARDS when COVID-19 hit us. And so we quickly switched over to Jeroen Mullinger. He's measured hundreds of COVID patients and spent hours in rooms measuring these measurements in COVID-19 ICU patients. So we needed data on this new disease. And so we made multiple metabolic measurements using ultrasound, BIA, metabolic cart on COVID patients to compare to echo. And the real question is, are these patients hypermetabolic? They seem so sick and hypermetabolic in their early phases, but the reality is they're not. This is a COVID patient on day 4 who's paralyzed and prone, but is reading only 78% of predicted, if you look back, versus Harris-Benedict. They're almost hypometabolic in the first week. And that's what we found. But then as they begin to recover, or they move into the second week, even if they're very sick, their needs skyrocket, up to 2,400 calories, almost 35 kcals per kilo. They become very hypermetabolic. And that gets worse over time in some patients. This patient got much more hypermetabolic. This is like the burn patients I used to care for. They would have readings like this, 44 kcals per kilo. And then as they improve, they'll drop. Their key here is they're very variable from day to day and week to week. You can see this patient dropped to 28, and then a few days later became sicker, secondary infection, jumped back up. So this shows us we can't guess at our patients' needs. We won't be accurate. And in fact, this is John Whittle and some of our other trainees, Krista Haynes, who have helped us show this is the variability in metabolic needs of the COVID patient day by day throughout the ICU in 3-day increments. So our initial data shows they're normal or hypometabolic in the first week, and then they become very hypermetabolic in the following periods. So we have new data on a larger number of patients, and I'll present this in full at my COVID personalizing nutrition session later this week. But how well do predictive equations work versus the endocrinometer in this disease? And 2 of our research dietitians did this work, and was only published just 2 weeks ago. You can see there's this escalation of metabolic needs over time that clearly increases over time, but the reality is, how well do the equations do? This is what the metabolic cart shows. These are what our Aspen equations show. So again, they don't do well early, they don't do well late. Penn State does about the best, but it cannot predict the late hypermetabolism in any way, shape, or form. And the typical Harris-Benedict and MSJ equations perform terribly and would not be useful in a COVID patient at all. Interestingly, obese patients don't seem to change their hypermetabolic state much at all. From week 1 to week 3, they seem to stay the same, whereas non-obese patients do change. We've never seen this phenomenon in any other kind of patient. And so we're looking at other non-COVID obese patients with this new device as well. But this is interesting. Obese patients seem different. And the yellows here shows where all these equations perform poorly. These equations are not performing well. So this study shows a unique hypermetabolic pattern in these patients, much like a burn, that persists out to 7 weeks, much later than our typical Cusperson curves would show, that may not be present when patients are obese versus those that are. And so the endocrinometer is essential. If you don't have one yet, use Penn State. This is a suggested algorithm that's in some of the papers we've published about how you can use endocrinometry in your care. So as we finish, how can we personalize nutrition management in our patients to create survivors and not victims of our patients by targeting feeding and measuring the effect of our nutrition on muscle? Like in all specialties, especially in nutrition, we need to do better. You can see these green dotted lines was our guess at calories over the years without metabolic cart, but the reality is we actually weren't that close. This is COVID-19 data, and maybe that's a different disease, but we will see. But we need to measure the right patient, right dose, right patient, right time. We have many new options, many new devices. Some are already at our bedside that we can use to do this. But we need to be doing this objectively. Our exercise studies can't just be go exercise. They need to use CPET to guide high-intensity training. That's something else I'll talk about. But Lord Kelvin said it best. We have to measure it to improve it. And we have lots of opportunities with ultrasound, with metabolic carts, with BIAs, and many other devices. CPET-guided exercise, which is a different topic for a different day. But our hope is, in closing, by doing this, we can take patients who look like this, have them walking on their ventilators very quickly like this, and ultimately the ICU like this, or at least like this. And with that, I'm happy to take your questions. Thank you.
Thank you, Dr. Wishmeyer. Excellent talk. One quick question, anyone? I think these tools are amazing, and we look forward to deploying this type of technology in our ICU as soon as they become mainstream and available for all of us. Okay, let's go ahead and move on. Thank you, Paul.
Thank you.
Our last speaker before we take a quick break is Dr. Sagel, who is going to talk to us about perioperative therapy. And I apologize to our speakers for running a little late. We're going to try and get back on track. Looks like we have a bit of a break after you, Dr. Sagel, and then hopefully we'll be on track for our 10:30 session.
Well, good morning, everybody. Thank you very much. Dear moderators, ladies and gentlemen, it will be a pleasure to contribute to this session on personalized medicine with a talk on perioperative goal-directed hemodynamic therapy. These are my conflicts of interest, and well, if we talk about perioperative goal-directed hemodynamic therapy, we need to acknowledge that we talk about a very vague term. So what are we talking about? We may define goal-directed therapy as a hemodynamic treatment strategy that includes the titration of therapeutic interventions to predefined target variables, and with the goal to optimize global hemodynamics, whatever optimize means, and to eventually maintain organ perfusion and oxygenation. So if we talk about goal-directed hemodynamic therapy, the main question, of course, is how to define the goals. In the context of this session, I would like to ask, should we personalize hemodynamic targets, and can we personalize hemodynamic targets? Well, if we take one step back, if we take care of patients during surgery or after surgery in the intensive care unit, we aim to optimize organ perfusion pressure, and we aim to optimize oxygen delivery. To optimize organ perfusion pressure, we need to optimize mean arterial pressure, because mean arterial pressure is the inflow pressure of most organ systems, and together with the organ-specific outflow pressure, it determines the perfusion pressure. If we want to optimize oxygen delivery, we need to optimize arterial oxygen content on the one hand and cardiac output on the other hand. And to optimize cardiac output, of course, we need to optimize stroke volume that is mainly determined by intravascular fluid status, myocardial contractility, and afterload. So, giving that framework, I today will not focus on goal-directed therapy per se, but I will split it up and talk about blood pressure and cardiac output management. So let's start with blood pressure management. I could now show you numerous retrospective registry analyses that show that there is an association between a low blood pressure during surgery and after surgery and postoperative organ injury, especially acute myocardial and acute kidney injury. I will not show you all of the available retrospective analysis, but I will show you one retrospective cohort study in more than 20,000 non-cardiac surgery patients. And I show you this one because the authors aimed to answer the question, what is the absolute population harm threshold for acute kidney and myocardial injury? And if you look at the figure, you may say that the probability for acute myocardial injury and acute kidney injury increases when the lowest mean arterial pressure for a cumulative 5 minutes is somewhat below 60 to 65. So this sounds easy, so we can kind of conclude that there is evidence from registry analysis that suggests that the intraoperative population harm threshold for organ injury is around 60 to 70 millimeters of mercury for mean arterial pressure, and that we therefore kind of recommend that we should keep blood pressure above this threshold. But of course, we need to ask a question whether a blood pressure of 65 is the optimal blood pressure for every single patient we have in the ICU, or that we care for during surgery. And of course, this is not the case, and if we talk about individual patients, we need to think about blood flow autoregulation. Blood flow autoregulation keeps blood flow constant within certain limits of perfusion pressure, and the important issue about it is that blood flow autoregulation depends on an individual normal blood pressure. So, for example, in patients with chronic arterial hypertension, the autoregulation curve is shifted to the right towards higher pressures. So to get a better idea about individual blood pressure physiology, we performed a prospective observational study in more than 300 patients having elective non-cardiac surgery. And what we did, we performed ambulatory blood pressure monitoring for about 24 hours, days or even weeks before surgery, and we then compared those ambulatory blood pressures to blood pressures that we observed during surgery. This allowed us to compare the lowest nighttime mean arterial pressure against the population harm threshold of 65. And you may ask why we chose to look at the lowest nighttime mean arterial pressure. Well, we assumed that the lowest nighttime mean arterial pressure somehow reflects an individual safe threshold, because people usually don't wake up in the morning with acute kidney or myocardial injury. So we compared this individual safe threshold against the population harm threshold of 65. And what you can see from the simple histogram of the differences between the lowest nighttime mean arterial pressure and 65 is that the differences vary considerably among individuals. To put it simple, about 1/3 of the patients had lowest nighttime mean arterial pressures well below 65, but 2/3 of the patients had lowest nighttime mean arterial pressures well above 65. So from that, we concluded that the population harm threshold of 65 is not the individual safe threshold. And of course, there are differences between physiologic sleep and general anesthesia. But in 1/3 of the patients, the mean nighttime pressure is below 65, and those patients presumably tolerate pressures lower than 65 also during surgery. But in 2/3 of the patients, and that is the important message, the lowest blood pressure during night is never even close to 65, and those patients may need higher pressures during or after surgery. So should we personalize blood pressure? Well, there is only one randomized controlled trial in almost 300 patients, and it investigated the effect of individualized blood pressure management versus routine blood pressure management with a primary endpoint of organ dysfunction after surgery. So the objective was to evaluate whether an individualized approach reduces postoperative organ dysfunction. The intervention was interesting. Individualized blood pressure management consisted of achieving a systolic blood pressure within 10% of the reference value, and the reference value was the preoperative resting systolic blood pressure that was obtained by a single measurement, either during preoperative anesthesiology consultation or on the surgical ward just a day before surgery. There's one major limitation to this study, and that is that the individualized group and the routine group patients were treated with different vasopressors. So this is not only a study on different blood pressure levels, but it's also a study on different vasopressors. Nevertheless, while the primary endpoint was a composite between systemic inflammatory response syndrome and a failure of at least one major organ system within 1 week after surgery. And if we have a look at intraoperative pressures, you see that the median intraoperative blood pressure was higher in the individualized treatment group. But to draw better conclusions, we would probably need to look at areas under certain thresholds that are not provided in the study. Nevertheless, the individualized treatment group had higher pressures, median pressures, but the results were impressive. The composite primary endpoint occurred in more than 50% of the patients in the routine management group and in only 38% of the patients in the individualized management group. So from that one relatively small randomized controlled trial, we may assume or conclude that individualizing blood pressure management during surgery reduces the risk of postoperative organ dysfunction compared to routine care. Well, what about cardiac output management? That is even more complex than blood pressure management. There are now more than 100 relatively small randomized control trials on cardiac output-guided, goal-directed hemodynamic management. And if you summarize all this evidence, you may say that there is evidence that goal-directed therapy reduces postoperative mortality compared to routine care, and you probably need to treat around 60 patients to benefit one patient, or to put it differently, you can save 18 lives if you treat 1,000 patients with goal-directed therapy. But what does it mean? If you reduce mortality, or the effect on mortality is especially pronounced in patients who are monitored with a cardiac output monitor and not with other hemodynamic variables, for example, like functional preload variables. So we should focus on cardiac output, but the problem here again is there is a huge inter-individual variability in cardiac output and stroke volume between patients. So this is a study in healthy volunteers, and as you can see, the cardiac index and stroke volume index values vary substantially between individuals, and there is a clear association with age. So with increasing age, cardiac index seems to become lower. So then, should we again personalize cardiac output measurements, cardiac output management, and kind of define the cardiac output treatment goal for every single patient? I will not be able to answer that definitely, but I will show you two trials that took two different approaches to individualize cardiac output management. And the first trial is, well, everybody of you knows that trial. That was the optimized trial that was published in the JAMA in 2014. And what was done in the optimized trial, there was some kind of an individual maximization of stroke volume and cardiac output. So cardiac output and stroke volume were maximized, but on the personal physiology of each individual patient, because they received fluid boluses and an inotrope to push the patients to the flat part of the strength-starting curve. So it reflects individual physiology, but still aims at maximizing the cardiac output in each single patient. You know that this was the largest trial in that area that we have. They included more than 700 patients, and patients were randomly assigned to cardiac output-guided management or to routine care. And you also know that there was a treatment difference between the groups. The primary endpoint, moderate or severe complications or death, occurred in 43% in the usual care group and in only 37% in the cardiac output-guided group. But this difference, although it may be clinically important, was not statistically significant. So we recently tried to go one step further, and we performed a trial investigating whether personalizing cardiac output management and targeting the baseline cardiac index value that the patients have before surgery improves postoperative outcomes. It is a relatively small single-center randomized control trial, like a proof of concept trial. We also looked at complications and mortality within 30 days after surgery. What we did, we measured cardiac output the day before surgery in the resting position, and we did that using non-invasive pulse wave analysis, and we then defined the personal resting cardiac index value for each single patient, and we used this individual target for intraoperative management, and that that individualized cardiac index value then triggered fluid and inotrope therapy. Interestingly, the baseline cardiac index again varied substantially among individuals, so it ranged from about 2 to 5 liters per minute per square meter in both groups, kind of justifying that we use different targets for different patients. And the primary endpoint occurred in more than 50% in the routine management group and in only 30% of the personalized management group. Again, this difference is of course clinically important and also here statistically significant. So we concluded that personalizing cardiac output management reduces postoperative complications compared to routine care. So I hope that I was able to convince you that perioperative hemodynamic management should not be based on poorly characterized patient populations. In the future, we, of course, should aim to perform real precision medicine, but for this, we will need some kind of genomic or metabolic profiling. But what we can do in the moment is we can personalize our treatment. Especially in perioperative medicine, we have the unique opportunity to not use population-based normal values that are supposed to be normal for everyone, because, well, population-based normal values do not necessarily match or represent the personal normal values. There's a huge inter-individual variability, and in perioperative medicine, we can assess pre-induction baseline values patients have when they present for surgery, or we can even look for ambulatory personal normal values days or weeks before surgery and use those personal values during hemodynamic management in the OR and after surgery in the ICU. Thank you very much for your attention.
Thank you, Dr. Saugel, for the summary of these interesting data. I think it makes perfect sense to personalize these hemodynamic parameters. Any questions from the floor, please? If not, I was a little bit intrigued by your finding of identification of patients who seem to be safer going lower than this magic goal of 65. And I was wondering, are there any specific clinical characteristics of these patients? And I'm asking this because I guess you're familiar with, during nighttime in ICU, often the nurses put on the norepinephrine because the blood pressure drops. And in my mind, we should perhaps sometimes not do that. So can you inform us?
Well, that is a very difficult question. I'm always a little bit, I hesitate to show these data because they trigger this question and they kind of bring me in a position where I need to defend that we should still go for 65. So my personal opinion is that just for safety reasons, we should at the moment not go below 65. Those patients who are well below 65 during night are usually younger, more often female than male, and well, physiology kind of suggests that they may tolerate lower pressures during surgery or in the ICU, but I think there is overwhelming evidence at the moment that at least on a population level, risk for organ injury starts to increase with 65, that I think it's a pragmatic approach to not go below 65 in any patient at the moment, but to identify those patients, for example, with chronic arterial hypertension, who probably need higher pressures. From a physiologic perspective, your question is completely reasonable, but from a pragmatic perspective, I wouldn't go below 65 at the moment.
Well, thanks for these cautionary words then. We're scheduled to have a little bit of a break, but we're running late, so I suggest that we just move on. So thank you, Dr. Saugel. We're moving to the brain, and the next speaker is Dr. Fabio Tacconi. And he will speak about the use of neuromonitoring to guide therapy. Dr. Tacconi.
Oh, thanks a lot, and again, welcome everyone again to ISICEM 40. So I will try to share with you some thoughts about how neuromonitoring can guide therapy in brain-injured patients, and I will take as an example TBI, and probably some of the things I'm going to tell you can be also translated in some other forms of brain injury. So our therapy, basically, when we face an acute brain injury, is to minimize or reduce the occurrence of secondary injuries. Some of the injuries can be easily monitored at the bedside because they occur because of systemic events, hypotension, hypoglycemia, hyponatremia, for example, or hypoxemia. But there are some, of course, secondary injury which are driven by specific cerebral events, and the most common one that we are aware of in TBI is the occurrence of brain edema. And this is where monitoring, specific monitoring brain parameters can be important. In this consensus we published in 2014, we underlined the need of monitoring to detect very earlier, as soon as possible, the occurrence of these complications, potentially change or guide therapy. And of course, the idea behind this is this change in therapy can influence patients' trajectories. And the monitoring that has been implemented since years now in the monitoring and the treatment of TBI patients, for example, ICP monitor. Now, the point is that when you want to know how to use this monitor in your patients, of course, you refer very often to guidelines. What the guidelines do, that they try to evaluate the evidence and give you some suggestions and give statements on how to apply therapies to, for example, titrate and, in this case, reduce the occurrence of brain edema. At the point that they give you more information on the safety zone. You have to avoid very high ICP in the patients, but it doesn't tell you how to optimize the patients. It is possible for the level of ICP that with different tolerance at that level of ICP according to the patient situations. And you see the guidelines here. You say at the underline that you should treat the patients with ICPs more than 22 because this has been associated in observational studies to poor outcome, but it doesn't tell you anywhere in these guidelines how to reduce ICP. So there is a trigger point, but you don't know how to reduce ICP in these patients. And this is why we've tried in a consensus document to address the concept of level and intensity of care. When we start from what we call the tier 1 intervention, effective but with very few side effects, and we go up to tier 3 therapy, very effective to reduce ICP, but with the risk effectiveness balance that put them at the end of this therapeutic strategy. Even if this is a kind of ICP-driven therapy, when I go to the bedside and I see on the board of the patients what has been recommended to treat, I often see this. Keep an ICP between 20, CPP more than 60, temperature less than 38, and everything that you see. It looks like if we base our therapy on magic number, and specifically for ICP, it's a little bit weird to see that the patients at 21 is doing well, at 23 is doing bad. It's a bit not so physiological. So all this kind of intervention we see in the protocol in the ICU does make so much sense in terms of physiology, the individualized care at the bedside. You can easily understand that the patients with this kind of CT scan, whatever would be the ICP, it will require an urgent surgery, while this kind of patients can benefit from an optimized medical care to titrate ICP in these patients, and the concept that one size does not fit all perfectly match with the management of TBI patients. The other point with ICP alone is that we know how complex is brain physiology, but when we look at how we basically base our therapy in the TBI patients, it's like ICP and CPP. It's got a very, very easy approach. When I want to compare neuromonitoring with the modern systemic monitoring approach in management critically ill patients, well, we don't use only CVP and MAP. I heard from Antoine, we can use, of course, echocardiography, but we integrate also indirect parameters assessing cell happiness, like, for example, lactate, for example, tissue oxygenation, and we have a more complete picture to try to select the therapy on the bedside. So this is quite complex. We can comment which is the best one, but you try to use all of them to make a decision, while in TBI patients you have only ICP, CPP, which look a little bit limited when you look at the complexity of brain physiology. So if you just look at brain edema again, it's only one of the pathways that are involved in the complication and secondary brain damage. And if you just titrate ICP, you will miss information on all these other pathways that can occur even when ICP is within normal ranges. So the point is that, can we do something? Yes. Can I try to individualize, for example, the level of ICP, trying, for example, to avoid tissue hypoxia? Because when there is tissue hypoxia, there should be a secondary damage and some, for example, cellular death. So can we do this at the bedside? One of the approach would be, I'm not interested in oxygen itself, but I want to keep a constant cerebral blood flow. I want to avoid, and when there is changes in mean arterial pressure or changes in CPP, there are large fluctuation of blood flow that can potentially expose the patients either to brain hypoperfusion or, when the CPP is too high, to the potential risk of increased brain edema. And this is the concept you heard in the present lecture. This is true for all the organs of autoregulation of blood flow. And this is, let's say, a representation of the Lassen curve. We don't know exactly which are the level of pressure that are really able, within level of pressure where the CBF kept constant, but this correlation is totally disrupted in acute brain injury patients. So we need to do this at the bedside, trying to keep a constant CBF, which will be a situation of safety for our patients. Can we do that? Well, there are different indices at the bedside that, connected to specific software, can give you in the real-time situation a value of the autoregulation. So you could say, I can evaluate autoregulation at the bedside. I look at the level of CPP where the autoregulation works the better, which is the CPP optimal, and I try to treat my therapy according to this value. And this is the concept behind the Cogitate study, which is a phase 2 randomized trial, recently published in Journal of Neurotrauma, I think a few days ago, where the authors randomized TBI patients to have a standardized ICP-CPP therapy based on fixed value, or an interventional group where the CPP was selected according to the autoregulation. So the software analyzes the data every 6 hours, and gives a proposal to the authors, to the physician. The physician can decide to take it or not, and they can change CPP. It's not specified how to do it, but you have to change the CPP to optimize autoregulation. Is this feasible? Well, it is feasible in 72% of proposal, which means that still in a fourth of patients, in a fourth of recordings, is not that the software is not able to provide an adequate CPP. But when there is a CPP proposed by the software, in most of 95% of the recordings, the physician decides to apply this value. Basically, what they have observed is that there was a change in practice. We can say statistical significant, although the difference CPP was 81 in the control group and 86 in intervention, so a small difference. And so they said it's feasible, it's feasibility study, it's totally safe. There are no more complications or increased pressure or give more fluids to increase CPP in these patients. They also reported data on outcome. There is a quite significant difference in outcome in favor of the interventional group, but they also stated there was imbalance and baseline characteristics that prevent to go further into discussion. But this is a good basis to potentially go for a phase 3 randomized trial to potentially see how optimized CPP at the bedside using autoregulation can change the outcome of our patients. Now, one of the criticisms we might have is that autoregulation is just the stability of the flow. It doesn't tell you anything about brain oxygenation. You may have a total normal autoregulation, but still the level of flow is not adequate to meet the metabolic need of the brain. So if you want to see whether there is tissue hypoxia, you need to measure it. And the most optimal way to measure it is an invasive catheter, and we have association of brain hypoxia measured with this catheter with outcome. Why measuring this tissue oxygenation is important? Because it doesn't correlate at all with ICP and CPP. You may have normal ICP and tissue hypoxia, CPP with normal levels of tissue hypoxia. If you don't measure it, you will not identify the presence of a deficit in oxygen supply to your patients. The point is that when you obtain this value, you need to interpret the value. It's not just a matter of flow. You might have tissue hypoxia because the flow is inadequate, hypotension, hypocapnia, for example, because there is a reduction in oxygen content, maybe anemia or hypoxemia. There might be an increase of consumption. The flow is perfectly okay, but there may be seizure, increased temperature, agitation that you need to compensate, or in some cases, like for example in sepsis, it's just a matter of macrocirculation or diffusion, and so there is a problem of diffusibility of the oxygen from the vasculature to the tissue. So can we apply this at the bedside? Yes, we can. There are many centers that use this at the bedside. And then you start to combine ICP and oxygen, and your therapy is more individualized, not just reducing or not ICP, but you may have an elevated ICP with a normal oxygenation. You won't treat in the same way that an elevated ICP and a low oxygenation. Why you might have elevated ICP and normal oxygenation? Maybe the patient is just waking up. Maybe it's just hyperemia. But if there is hyperemia, I can just hyperventilate. I don't need to give osmotic therapy in these patients. While, of course, you might have a normal ICP and a normal oxygenation, which means the patient is fine, and sometimes you give nothing. And in ICU, sometimes doing nothing is also a good decision. Now, can we individualize the therapy? Yes, because at that moment, rather than giving to the nurse or having a protocol where I use a fixed dose of CPP or a fixed target of ICP, I would say look at the oxygen and increase the blood pressure if the oxygenation is reducing. I can then the individualized ICP threshold. This patient doesn't tolerate an ICP on 17, I have to reduce further. This patient doesn't like 60 CPP, I need higher CPP. I can decide how to titrate my oxygenation, how to titrate my CO2, when to transfuse, when to stop sedation. Everything can be titrated according to, let's say, the happiness in terms of oxygen supply of the brain. So just to present you some work from my group, on the left side, we have an increase in CPP in brain injured patients. What is important to me is that there is a half of the patients who will respond to the increase of CPP. It's not because you increase CPP in all the TBI patients, the brain injury patients, that this will result in increased brain oxygenation. And the same could be for transfusion. Transfusion is very often used to potentially increase brain oxygenation in the severely brain injured patients, but we don't have a threshold. If you have a monitor that tells you that there is a concomitant tissue hypoxia, there is 40% of responder. Again, not all the patients will respond to this intervention, and the best way to identify those who will respond is the presence of tissue hypoxia at the baseline. So the monitor identifies patients at risk and also identify responders according to your intervention. Now the question is, of course, there's a repetition of the slide, does it work? Because we need to improve the outcome. We have a phase 2 randomized trial in TBI that has compared ICP protocolized care versus ICP versus plus PBO2 protocolized care, showing that you can reduce the occurrence of tissue hypoxia. This was the aim of the study. And there was, of course, it's a phase 2, trends toward a better outcome in the group ICP plus PBO2. And this is why now we have randomized clinical trials running all over the world. The Boost 3 trial, the Bonanza in Australia and New Zealand, and the OxyTC, which as far as I know is completed in France, which are trying to respond with a larger cohort whether ICP plus PBO2 complex protocolized care is better than ICP alone. Of course, you may question about whether looking at the metabolism makes sense. We can do this at the bedside with cerebral microdialysis, which is today more a tool of research and a tool of clinical application. There are many papers on cerebral microdialysis, but most of them use post-hoc analysis of the information. They don't apply a protocol to change the therapy at the bedside. But again, you can have patients with a normal ICP and a normal PBO2, which might still have alteration of the metabolism. Sometimes it's just mitochondria. If it is mitochondria, I don't know how to do in these cases, but some of these TBI patients present some increased metabolism of the cells, like an excess hyperglycolysis, which could potentially be treated, and we have some preliminary data where, for example, in case of hyperglycolysis, you can potentially shift the metabolism of the cells, giving an alternative substrate like ketone bodies or hypertonic lactate, which can potentially spare the glucose and reduce this metabolic distress identified by lactate to pyruvate ratio. Again, it's more a proof of concept. We are really at the beginning of this investigation, but you can go farther in your analysis and look not only at the oxygen, but also at cellular metabolisms. So in conclusion, the neuromonitoring is used at the bedside today to titrate our therapies, because most of the centers we already use ICP and CPP. The point is this is very limited. It doesn't give us the complete picture of the brain. So we need a multimodal approach. I mentioned the oxygen and the metabolism. Someone else could say, why don't EEG? Yes, EEG too could be implemented in this approach, because we need to better understand brain physiology, and only combining this monitoring can potentially result in protocolized care. Protocolized and individualized. Of course, whether this change outcome, I put a question mark, needs to be demonstrated in future studies. Thanks for your attention.
Thank you very much. So our conference organizers have only given the speakers 15 minutes and no time for questions, so we're going to go ahead and move on. And I'd like to introduce Giuseppe Citterio, who will talk about biomarkers and neuroimaging. Thank you.
Thank you very much. And the aim of this talk is more general. I think if you work in a general intensive care unit, sometimes you have some TBI admitted in your unit, and you have to ask yourself if you need to make a CT scan, if the trauma is not so important, if the patient is conscious. And sometimes you have a question if you need to have an additional imaging like MRI. And I'm not David Menon. David Menon was supposed to make this presentation. He sent me the slide. We worked together in the Center TBI collaboration, and he asked me to present them to you. The question is, as Fabio presented earlier, we have some complexity to deal with in traumatic brain injury, and we are not so good in phenotyping this kind of patient, because when the TBI patient arrives to the hospital, we look clinically and we look at the CT scan. And we have some biomarker coming to be used. And as you think about TBI, cardiac arrest, S100 and NSC are usually routine, but we have also glial fibrillary acid protein coming, as you see, from astrocyte and blood-brain barrier, and also UCH-L1 that comes from the neuron damage. So, and thinking about degenerative disease, also tau protein. So we have some other biomarker we can study. And I think the question we are trying to address in the next 15 minutes is which biomarker could be useful to be measured in TBI, and if this biomarker could help us in identify patients that could benefit of a CT scan or to repeat a CT scan, and to select patients that could have a second-level imaging like MRI, and if we are able to integrate this data in the patient care. If you think about how we select patients for having a TBI, for having a CT scan after a TBI, it's very simple. If you have a severe patient with a Glasgow Coma Scale below 8, the patient is comatose, the patient goes from the emergency department to the CT scan. It's less clear with patients with borderline GCS, like 13, 14, 15. So it's difficult to understand when to do and when to repeat the CT scan. If you look at the suggestion from guideline, as you can see in this plot coming from the BNJ, there are, for example, knees that have high specificity and low sensitivity, and other that have high sensitivity and low specificity. So looking at the probability, for example, New Orleans criteria have a sensibility of 99% and low specificity. So we can have a lot of CT scan in patients that don't need a CT scan. Knees the other way around. So we are missing sometime around 25-27% of patients with lesion applying the criteria, only applying the criteria. So biomarker in this setting could help improving the performance of this clinical suggestion. And for example, the Scandinavian CT scan algorithm that in certain S100 is seen to be cost-effective, didn't change the outcome, didn't found an increase in sensitivity and specificity, but reduced the cost, avoiding a CT scan in patients that didn't need a CT scan. But going further, the new biomarker we presented earlier as a GFAMP and UCH-L1, in a large study, retrospectively done, they sampled the patient have a score between 9 and 15. As you can see in the plot, the CT scan positive are these two white bar in the middle of the two biomarker, GFMP, the upper part, and UCH-L1, the lower part. As you can see, there is a signal that the patient with a positive CT scan have an increase in biomarker. And I think most important, if we don't look only at sensitivity and specificity, look at the negative predictive value. So you can say that you can exclude a pathology. And as you can see, both biomarkers perform very well. And probably inserting this information in the rules we presented before could be useful. But probably we need a point-of-care analysis. And this comes from the Track TBI collaboration that has been founded by the American Army and the NIH, because if you think about some setting, for example, the war field, if you think in an emergency department crowded by many patients coming from an accident, you have to select on the right time, not retrospectively, which patient could need to have a CT scan. As you can see, the two biomarkers we presented, 0.6 hour post-injury in a point-of-care analysis, have a good performance, both of them, and GFMP is better than the S100 in this setting because identify more frequently the positive CT scan with a sample done in the emergency department. And if we do the same in other series, CT scan positive and CT scan negative with two different biomarkers, GFMP is this one, UCH-L1 this one. You can see that this one is performing much better. And if you look at the idea of having negative predictive value, we have a number around 99% in the patient with a Glasgow 13-15. So you can exclude the need of CT scan in patients less severe using biomarker. In the Center TBI collaboration, we collected 4,000 patients, and 2,800 of them had a CT scan, early CT scan, and biomarkers sampled at the hospital arrival. And we have different strata from emergency department, admission to the hospital, and ICU strata. And as you can see, all the panel we tested and all the biomarker we already discussed. The red box is the positive CT scan. The blue box is a negative CT scan. This has been done on all the more than 2,000 patients. You can see that the positive CT scan patient with strata, emergency department admission and ICU, this is severity going from mild to severe. All the strata give us a signal. When there is a positive CT scan, biomarker are able to identify them. And if you look at some of them, they perform better than others. And summarizing the result, the biomarker performing better is GFMP, blue bar in all the setting, overall mild, Glasgow 13, 14, 15, on all the panel is going to perform better. But the gray box, the gray line is putting together more than one biomarker. We didn't test the possibility to add the value of a single biomarker to other in this setting. The problem comes when we look at the overall population in center TBI. We have around 60% with positive CT scan. We are talking overall patient coming to the intensive care unit, to the emergency department, or to neurosurgery. And you look here, we have some patient with a CT scan negative and MRI positive, so contusion, traumatic axonal injury. And I think one of the questions is if we are able to identify this patient with a CT scan negative and a need of an MRI, and if this lesion could impact outcome. And looking at this question, we need to think about, because in some patients we are going to apply advanced and extreme therapy. Fabio said that we are guided by monitoring system, but in some patients we are thinking about hypothermia, decompressive craniotomy, barbiturate, and we need to understand if the problem we are facing is a single problem or rise of ICP, or the patient could not be saved even if we are able to control ICP because there is a brain damage, for example, of a brainstem due to the diffuse axonal injury. So probably having a biomarker identify patient that in this setting could benefit to have an MRI will be beneficial for sure. And if we saw the candidate we have, GFMP, you saw CT scan positive, CT scan negative, we are able to identify the lesion of the CT scan as we said, but also we probably could do it also in identify patient that could need a magnetic resonance imaging, a second level imaging. And the information comes from the track TBI cohort, the American cohort. As you can see in the patient moderate TBI 13-15, Glasgow Coma score, we have around 800 with negative CT scan, 500 did a MRI, and as you can see, they were able to find 120 positive MRI CT scan over 500 CT scan MRI done in patient with negative CT scan. So how can we identify this subsetting? They try to test GFMP in this setting. As you can see, looking at the sensitivity and specificity curve here presented, there is a good relationship between this biomarker and the presence of lesion on MRI in patient with a negative CT scan. And this could be done very early, 0-8 hour, till 12-24 hours after trauma. And I think, as David presented, as you see, I'm Giuseppe Citera, but he's still David Menon presented to you. This is David Wisdom, because he said that some information I'm giving to you are medicine-based evidence, not evidence-based medicine. So I think we say that the current CT scan decision rule don't have optimal sensitivity and specificity, according to which you can increase sensitivity or specificity. In some cases, you will do more CT scan than needed. In others, are missing some lesion. And probably adding in the future biomarker, trying to better profiling the patient, better identify the patient that need a CT scan could help us in improving our possibility to identify a lesion. Especially some of them, GFEMP, added, for example, to the knees or to the knock, could have different results. In a setting in which the guidelines give you high sensitivity, low specificity, could rule out the need of CT scan, or the other way around, in knees, in which you have high specificity, low sensitivity, you can identify the 27% of the patient that you could miss. Adding biomarker, you can select the patient for a CT scan. In ICU, this is less relevant because the patient already had a CT scan. And I think the second point is that in some patients with multiple trauma and early CT scan normal, and if you have some problem like high ICP, you cannot await the patient, you have seizure, and so you don't have a clear clinical assessment, biomarker could help us in identifying patient in which we can trigger to repeat a CT scan. The last point is that we can use also biomarker for identifying patient with occult CT scan lesion, for identifying subsetting, for having an enriched population, for having MRI in this setting, for identifying patient with diffuse axonal injury compared to patient without diffuse axonal injury, because both the two populations have a quite different outcome at the end. And also we can use different clinical approach to the two settings, knowing if a patient have a diffuse axonal injury of the brainstem, for example. I thank you for the attention, and I think what we presented come from Center TBI, Metrac TBI, many other information are coming. We are starting to, we are finished to evaluate genetics in this population. We are trying to profiling better the TBI population, has been said also by Fabio. We are still, let's say, primordial in doing this phenotype in TBI. Thank you very much for your attention.
Thank you, Dr. Citerio. I think these biomarkers seem really very helpful. There's actually time for a question if somebody from the audience has one. If not, I was wondering, because you focus on biomarkers and CT, I was wondering, what do you think about some clinical characteristics of patients to combine all that together in algorithms such as age or injury severity score? Or what are your thoughts?
What we did till now is to look only at less severe patients, because the question was if we were able to identify patients that could need a CT scan. But for sure, we need to put all the pieces together, because we have 4,000 patients in which we have a lot of data. We have early biomarkers, we have late biomarkers, we have biomarker till date 7. We have MRI in a subsetting of this population. We have genetics in this population we didn't use till now. And so putting the pieces together will help us also to have a better prognostic evaluation at the bedside early, at the bedside intensive care in the 3 settings we have. Patient that return back after trauma from the emergency department, patient that stay in the hospital, and patient in the ICU. So even if we finish, let's say 2 years ago, and we publish more than 100 papers coming from the Center TBI, there is a lot of work to do, and probably to be integrated in the clinical practice for better phenotyping and genotyping our patient.
Okay, great. Looking forward to more work from your group.
Thank you.
Thanks again. Okay, we're moving on to another era. Can I invite Dr. Ivor Douglas? Hello. He will talk to us about the timing of tracheostomy in ICU.
My thanks to Dr. Bassi, Dr. Jeffers, to the organizers. I can say it is a real pleasure and privilege to be back in person at a medical scientific meeting. I know none of us take this for granted, and I know that the information I'm going to share with you today will have some immediate relevance and pertinence to the work that many of us are doing back home. So I'm going to talk a little bit about today about a procedure that carries with it a burden and weight far more than just the procedure. The procedure itself is fairly inconsequential. I'm not going to talk about approach to tracheotomies particularly, but much more about some decisions around timing of tracheostomy, and most importantly, an approach that we can use to first personalize decisions, and in the future use a more precision approach to the information that goes into making these decisions. Now, I assume that most of us here have some clinical effort as well as the work we do in a scholarship. So let's look at a patient together. This is a 61-year-old divorced father of 3, alcohol user who was sober until 3 months ago when he lost his job, just around the beginning of the COVID pandemic. He's been on a ventilator for 12 days with ARDS complicating severe alcoholic pancreatitis, both of which conditions are stabilizing but not resolved. He is delirious, requiring sedation, and is intolerant to short-term pressure support ventilation. He's had non-oliguric acute kidney injury and has been on renal replacement, which is stabilizing but still requires a level of support. And his white count, hemoglobin are all in the normal low range. He does not have a documented care preference or an advance directive. This is obviously a very minimalist case. There are many things you would also like to know about this patient, but I'm interested just by, let's take a show of hands. Who would offer this patient a percutaneous tracheotomy today? One brave soul in the room. Mm-hmm. Who would continue daily efforts at weaning for another couple of days and reassess? Just a few more. Who's going to wait until day 21, because this is a younger man, he's never been intubated before, he's got a good chance of liberation. You're going to wait until day 21 to make a decision? Nobody? Who's going to recommend withdrawal of life support? So the rest of you are just going to see how this plays out. Okay, that's fine, and that's not unusual. In fact, I think that speaks to the challenge in equipoise in this question. So let's just look at a second case. This is one that literally is just through our ICU. 74-year-old on the 15th day of ventilation for COVID ARDS was prone for 6 days. Our group has published extensively on this issue of prolonged prone positioning. Lives in a multi-generational household and is in the US of Latina descent. There have been 5 members of the family with COVID in the last month. The oldest son is also in an ICU, not in our hospital. She has got some chronic comorbidity without great mobility. She's making some improvement. The FiO2 down to 50%, PEEP of 8, poorly tolerant of weaning, still delirious, has a platelet count of 122 and a slightly elevated creatinine and HbA1c. The family indicates the stated preference is to pursue all life-prolonging cares on mainly religious grounds, that it's not her decision to choose. So again, same group of questions, perk trach now. A few more, interesting. Continue daily SBT for another 2 days. She's on day 15. So the optimists in the group. Continue daily assessment through day 21, often until quite recently, a practice that was universal because of the concern about aerosolization for the time for doing a trach. And who suggests withdrawal of life supportive cares at this time, regardless of the patient's preference? Good. So I think that what we appreciate from these 2 cases is that they demonstrate a good spectrum of usual care practices, but a real challenge around what to do and how to use data-informed discussions. So let me emphasize that I want to touch on just 4 areas about timing, the current state, and then we'll talk about how to personalize it. So in brief, here's just a sketch of a meta-analysis that looks at either ventilator-associated pneumonia or mortality odds ratios favoring early or late so-called delayed trach. The timing for early in all of these studies is all over the place, but you could say around 10 to 12 days or earlier is early. And in general, the point estimate and confidence bound slightly favors early trach when in regard to VAP. And interestingly, when you take a whole spectrum of not very well-performed studies, the point estimate favors early trach for mortality. When you enrich for well-conducted studies, conducted with some spectrum of what early is defined, the point estimate and confidence bound for mortality risk ratio is to the left of unity. And so there really does seem to be, in a risk-adjusted fashion, some potential benefit in all comers to pursuing earlier tracheotomy. But this is a session on personalizing decisions. And so Anuj Mehta and I and several in our group have looked at this in large groups of patients. This is from a study back in 2015, but an important one because it used Medicare data from the US and looked at the variability in time to tracheotomy. And what you'll appreciate in this data set is that the spectrum of decisions exactly mirror what you had been challenged with, both for non-surgical and surgical patients, and that the change over time was a little bit trending towards more frequency in the 8 to 14-day range. The practice in many units is to get to day 7 and ask, is the patient going to be on for another 7 days? And if the probability is higher, is to move the decision up to day 10 or so. So when we look at risk-adjusted early tracheotomy rates here in day 7, what we'll notice is that there is a tremendous variability by hospital. And Anuj, in this very large piece of work, looked at this distribution for 2 common areas of diagnosis, pneumonia and trauma. And there was more of an inflection in practice with a large number of hospitals doing an earlier trach for trauma, but a very wide spectrum of practices for pneumonia sepsis. And so the question is, does this variability reflect a general equipoise on the procedure, or is there actually some variability at the patient or provider level that could be leveraged to enhance a better approach to personalizing this procedure? So I want to just highlight that in this particular session, we're trying to be fairly explicit about 2 broad conceptual frameworks that are useful for digging into this realm. Personalizing medicine focuses on patients based on their individual clinical characterization and considers the diversity of symptoms, severity, and genetic traits. Much of what we've heard is a layer that is more sophisticated, using molecular informatics and particularly systems biology approaches to develop the endophenotypic approaches that you've heard about just in the last talk. And this approach has been broadly defined as a precision approach where we enrich on various biologic and physiologic criteria to make informed decisions. Now, when it comes to timing of tracheotomy, the challenge here is that we have 4 intersecting domains. Patient, the surrogate more frequently and family than the patient, and then the counterpoise balance of clinician and society. I certainly don't need to emphasize that the patient perspective is central, but often not well reflected, and discord between the reflection of the surrogate, who is trying to balance patient suffering and issues of self-sufficiency, with a real challenge in probabilistic trade-off. And this seems to be a universal challenge independent of culture, where understanding the values and limitations of critical care and the downside impact of resilience, prolonged grief, PTSD, and decisional regret all weigh to counterbalance whether the decisions of the patient are being reflected. On a clinician and society level, there are very important aspects here that inform personalized decisions, because even individual clinicians have a variability of reluctance or enthusiasm to conduct discussions that heighten anxiety. And unfortunately, across the world, but very much a focus in North America right now, is the impact of implicit bias and misalignment with patient values when it comes to individualizing and personalizing care. We know that on a societal level, the impact of the tracheotomy is way more than just the procedure, but the downstream impact on health resource allocation and usually requirement for long-term ventilation and placement. So there are a lot of questions that have been recommended for performing a personalized approach to timing of tracheotomy, and these really reflect on the patient, provider, and societal impacts of the downstream effect, much more than the specific challenge of the surgery itself. It has been suggested that therefore we need a better approach that incorporates a quantitative understanding of the outcomes, particularly the risk of prolonged mechanical ventilation, the impact of other organ failures and functional recovery, and ultimately mortality. And the approaches that have been prioritized are very similar to those you've heard about this morning. The emphasis on the capacity for near real-time risk prognostication, using enhanced approaches for machine learning and ultimately using a biologically informed approach where you can develop predictive models, apply them in the clinical situation, and receive direct feedback. Our group, the Provent group, Terry Huff, Shannon Cross, and myself, been working on this for, about 15 years. And our initial work focused on developing a simple risk prediction score, the Provent score. We developed that as a day 21, one-year mortality prediction model. And this has been refined by people in our group and others. We also have a manuscript in review right now looking at a modification of the Provent score for COVID-19. But the bottom line is that this is a very crude effort to personalize and risk stratify the hard outcome of one-year mortality to inform decisions about receiving a tracheotomy. And you can see three circumstances here. A 45-year-old with trauma has a 5% one-year risk. A 48-year-old Afghan female refugee has a 60% risk. And a 68-year-old patient with pneumonia on dialysis has a 90% one-year mortality rate. Now, again, we're talking about here broad prognostication by risk rather than personalization, but it certainly is a beginning approach because from there we can try to work away from imprecision medicine to a more precise approach that has been advocated, for example, in neuropsychiatric studies, trying to understand how to fractionate large populations. One of the approaches that has been studied fairly extensively by Chris Cox, Sharon Carson, and our group is trying to then incorporate evidence with preference. And the approach that has been popular, but not particularly well validated, is the use of a decision aid, which is a structured communication tool and a set of information that tries to incorporate qualitative with quantitative information to determine the appropriate time and relevance of tracheotomy discussions with a family or surrogate. And so in this study, Chris published a very large randomized trial where using a decision aid or control, he met with the families, and then we followed up with subsequent conferences and then home and looked at the outcomes of 192 decision aids, 252 family meetings. And then what we then looked is how did people's decisions change as a consequence? And the general tendency is that while decision aids reduced hospital costs, they did not increase prognostic concordance between patient and surrogate. They did not change decisions about goals. They did improve the outcomes that were important to stakeholders, and they didn't improve or mitigate surrogates' remarkably high levels of prognostic optimism. And the take-home is illustrated in this figure, where the trend in orange is away from less conservative interventions to even more aggressive interventions with the surrogates on behalf of families who were exposed to the intervention. So in some respects, one wonders to what extent this was a helpful or harmful intervention. And the problem is that we still don't really understand if we have the right precision in prognostic tools. So what about COVID-19? This useful image looks at the balance in COVID-19 between all the accumulated effects of PIC syndrome, airways problems, rehabilitation challenges, and counterbalances with the long-term consequences of ongoing mechanical ventilation. And in a conceptual framework, identifies whether early tracheostomy or delayed tracheostomy has been met as a pivot point. Now, again, this is actually helpful because it defines domains for consideration. At the moment, there are several large expert groups that have made some consideration about this. And the bottom line is that the working recommendation is really no different in COVID pneumonia or COVID respiratory failure than it is in general respiratory failure. Consider tracheostomy in day 20 to 21 after intubation, and several expert groups deciding not to make an evidence-based recommendation. So what goes into considering this? Well, clearly virologic factors, patient surrogate factors, clinicians, the surgical willingness and availability, institutional and regional and LTAC availability. In this Wien-Trach study, the patients were looked at and divided into a late trach or early trach, late in red, early in blue. And what you'll note is that while complications were numerically less frequent, There were no differences in tracheal stenosis, stomal infections. The only difference, other than shorter ICU length of stay, was a reduction in sedation delivery. There was no difference in survival for these patients. There's also continued challenges with concordance between the surrogates and the patients, such that it's not even clear that surrogates reliably represent the patient's opinions. So in completion, I want to highlight where this work goes. Our ongoing studies with our group is in the Prophecy study, or prediction of functional outcomes of chronic critical illness. And we've actually just finished enrollment looking not at survival, but at personalizing approaches based on functional outcomes. And the primary objective here was death or survival with severe physical and cognitive dysfunction in 6 months or 1 year. And we have just enrolled a good number of patients into the study, 589, and are completing the analysis. And just as an example of some of the enrichment strategies, we're using many of the neurobiomarkers, as well as some genotyping here of apolipoprotein E polymorphic alleles. And in our Prophecy study, 111 patients, we actually have seen a much higher gene allele frequency for the ApoE4 phenotype in patients who do select prolonged mechanical ventilation and have high levels of functional impairment. Putting it all together, of course, we are advocating that while personalization based on human factors and physiology are important, we are going to need to enrich our understandings of what predicts functional outcome in order to make precision recommendations for the future. So I thank the organizers again and very much appreciate your input and if there's time for questions.
Thank you, Ivor. We are running a bit late. This is an important topic for me as a tracheostomy patient myself. I think the idea of patient preference, should rank fairly high. Nothing is more important, at least nothing was more important to me than being able to be awake and participate in my care. Any comments from the audience? Okay.
I very much appreciate it, and I think it's the voice of the patient that ultimately we always desire, don't we?
Thank you. Thank you so much. Okay, I'd like to introduce Dr. Pelosi up to the podium. Paolo will be talking about mechanical ventilation.
Thank you very much, and it's a great pleasure for me to present this international collaboration. No conflict of interest to declare. And this is a paper we just published, and I was asked to chair a different group of people that we try to contact all over the world. And this was a multinational team, members from all continents. It was not easy to find each of them. Gender balance, I'm very proud for that. We tried to really have half and half among the authors in the different areas, and I think this is important for the future. Different expertise, some people more expert in respiratory mechanics, other in hemodynamics, other in other specific areas of mechanical ventilation. Each section was harmonized in a final version. We asked to each of them to focus on one specific issue, and then we try to harmonize all the draft, and there are some summary suggestions. So those of you who are interested, I think this is quite a recent summary regarding personalized mechanical ventilation. So the first point that we discussed was the rationale. So really we know that there is an untenable desire to standardize ventilatory management. And there are several randomized controlled trials and meta-analysis. We try to make summary estimates of the treatment for an individualized approach to mechanical ventilation. This is the aim, but there's a real definite causal link between the different applied pattern, VLI or death, and different outcomes as not really clearly established. And so this is the rationale why personalized mechanical ventilation based on lung physiology and response may helpful to develop and eventually inform a new generation of mechanical ventilation by, for example, artificial intelligence. So the first point that we discussed was tidal volume. We know that we should maintain in more severe patients relatively low tidal volume. But here we try also to discuss some particular issue. This is an example when we have a large amount of air and we apply a certain amount of tidal volume with a specific distribution of ventilation and driving pressure. If we have a reduction in the amount of aeration due to the progression of the disease, if we apply the same tidal volume, of course, we increase plateau pressure and driving pressure and the stress and strain on the lung. So we have to reduce the tidal volume and pressure in order to standardize the tidal volume of the aeration. And we know that there are these quite old meta-analyses that we performed, that of course there are some effects of high and low tidal volume, and interesting in that this is, I think, is very important. When we use high tidal volume, we can get better oxygenation, better compliance, better CO2, but overall, the mortality is higher. So don't look don't follow just the gas exchange parameters when you set your tidal volume. But we try to propose something new. One is the tidal volume according to the end-extreme lung volume, which can be measured in the new ventilators, but not for all ventilators. Another very easy method that might be considered is to use a sort of inspiratory capacity, so not looking at the expiration, but at the inspiration. So just performing a maneuver at 30 centimeters of water from 0 or 5 centimeters of water. And you see we can have different end-extreme lung volumes. And you see that inspiratory capacity, even if you don't know expiratory lung volume, is related to the end-extreme lung volume. So lower is the end-extreme lung volume, lower is the inspiratory capacity. And you can easily measure. And then you can standardize the tidal volume according to a certain pattern, which is around 20% of the inspiratory capacity. So this is just an idea and a suggestion, trying to make tidal volume more personalized, based not on end-extreme lung volume, which is more difficult to measure, but on inspiratory capacity. Of course, automated system and artificial intelligence might help us to select, control, and better monitor tidal volume. The other important parameters, is the driving pressure. Looking at the different papers, we found a threshold, a limit threshold, a left threshold of around 13 centimeters of water, but also plateau pressure, which is not always so much considered. We should maintain plateau pressure very conservative, and even more conservative than in the past. That was considered first 35, then 30. Actually, we suggested around 27. And again, if we look at this model, you see that if we increase the amount of volume by PEEP, we can decrease the driving pressure. But remember, even when we overinflate the lung by PEEP, we can further increase driving pressure. So high driving pressure may be due to too much volume, according to the aeration, but also to over distension. We know that this is the pioneeristic study from amateur team, the relationship between association of driving pressure and mortality. And we know from this recent study also that lower tidal volume and lower driving pressure is even more effective, more severe is the patient. So higher is the elastance of the respiratory system. And again, I would like to focus that it's not only a question of driving pressure, but is also a question of plateau pressure. Transpiratory pressure is increasingly used in our patients, but requires a very clear interpretation. This is just to remind you that we measure esophageal pressure just below the heart. And you see that the position is around 2/3 from the top. So when we measure the absolute number of esophageal pressure, we have to correct from non-dependent or dependent lung region of around 5 centimeters of water due to the different lung weight from the top or from the bottom. So we have to increase the pressure of 5 centimeters of water if we consider the pleural pressure estimated by esophageal in the dependent part, and we have to decrease 5 centimeters of water in the top. And this is an example. You see the transpiratory pressure below 0, for example. Then we increase the PEEP, and transpiratory pressure becomes positive. So these are just some general recommendations. The absolute difference not corrected between airway pressure and esophageal pressure at end inspiration or inspiration is the transpiratory pressure in the middle of the lung. This is based on animal studies. Of course, I have no time to enter into detail. You can read the paper. The driving pressure in the pleural and esophageal pressure, so that's the measurement of the elastance of the lung and chest wall, are very accurate. So the delta transpiratory pressure is very accurate in terms of absolute values. But when you have to look at the end expiration in the dependent part of the lung, the absolute transpiratory pressure should be computed as PEEP minus PES, esophageal pressure minus 5 centimeters water. So you have to correct for the gradient of the weight of the lung. And at end inspiration, so mainly at end inspiratory non-dependent region, the transpiratory pressure should be corrected plus 5 centimeters of water. Other proposal for the non-dependent lung region at end inspiration is also to consider the plateau pressure times the ratio of the elastance of the lung of the total respiratory system. So you have different methods, and from the paper you can go into the details, but these I think are the major suggestions. Mechanical power, you know, is a new area of interest. We consider the energy which is delivered by the ventilator to the lung and times the respiratory rate, the mechanical power. It's a long story. We have to include or not the level of PEEP. We personally believe yes. However, this is just to show you the mechanical power threshold from the clinical study, showing that mainly when mechanical power is above 27 joule per minute, we have to think about ECMO. Most of patients that require ECMO present a mechanical power above 27 joule per minute. What I like of mechanical power is that is a condensation, is a summary of the different factors that may induce lung injury, so we think more about different effects. And I see here John Marini here, respiratory rate. Respiratory rate is the forgotten sometimes variable in assisted ventilation and controlled mechanical ventilation when we set mechanical ventilation. We look at the plateau, the driving pressure, at the PEEP, mean airway pressure, whatever, but we don't look at the respiratory rate. And we know that the respiratory rate may make a difference. Alveolar recruitment, usually this is a long story. We can individualize recruitment at the bedside. This is a very nice recent paper, which is, of course, quoted and discussed in the summary paper. Just releasing the PEEP from 5 to 15, we can measure a shift of the pressure Warren curve. Higher is the shift, higher is the amount of recruitment. This can be even corrected in presence of a reclosure. And overall, it was proposed this RI ratio, which is the ratio between the compliance of the recruitment area divided the compliance at the lower level of PEEP of above a reclosure. So there are different formula, but just to show you that with this mechanical evaluation of recruitment, you can, and this index, you can have an idea if the patient is more recruitable or not at the bedside. Gas exchange is also important. There are different ways on how to set up the gas exchange in these patients. You know the well-known tables according to FI2 and the PEEP level, higher or lower. What we believe is that we should not force too much looking for excessively high level of oxygen, but try to minimize as much as possible the level of oxygen according to the possible ventilator-induced lung injury. Other parameters which are very interesting should be considered, like the ventilation ratio, which is the ratio between the actual ventilation and CO2 washout. With the theoretical one, we should be below 2. If it is higher than 2, means that the dead space is very high. And other new parameters like the entitled CO2 divided the PCO2 below 0.8 means that the patient is in a more favorable condition. Of course, if you can directly measure the dead space, but it's not available for all ventilators. Also, the PCO gap and of course, the saturation in the central vein and eventually oxygen transport are also other important parameters in the setting of PEEP. The lung imaging, I'm not too much on that, the CT scan, but remember, at least 2 levels of PEEP at the CT scanning, you have to get some pathophysiological ideas of what the densities means. You see this is an example when you have recruitment or not recruitment. Not easy to do at the bedside, so lung ultrasound has to be developed. I think has to be now implemented in the training of all intensivists, and I am also anesthesiologist. The AT is very promising. It looks only one area of the lung and less available in most of the ICU. So I think that lung ultrasound might be a very important tool to be used at the bedside. Phenotype were discussed before. We know there are different studies showing that we can have different phenotypes in RDS, but of course the translation of this is more difficult compared to the other clinical parameters discussed, and further research is important to be investigated. This is a part of the paper that was written by Bellomo in Australia. This is the physiological approach. We have to remember that sometimes physiology does not perfectly fit with clinical issues. This means this does not mean that we have not to follow physiology and not to study physiology. We have to know physiology and eventually then criticize some limits of physiology. The problem is that physiology measures whether a specific intervention affects a specific set of physiological parameters, of course, but physiology does not assess other unmeasured or unintended physiological consequences sometimes. And so better physiology does not necessarily mean that can be translated to improved clinical outcome. This is not a ban, of course, of physiology. The physiology is very important, but just to know that physiology has always to be interpreted with its possible clinical effects. So this is Ulysses and sirens. Sometimes physiology is more siren, so we have to be considered on that. This is the overall summary. So the rationale is that of personalized mechanical ventilation is to target a treatment for a personalization of the treatment. Tidal volume should be maintained very protective, but I show you that, for example, inspiratory capacity is a very good parameter that can be considered at the bedside for this targeting. Driving pressure and plateau pressure should be considered, and I show you some important interaction with low aeration and over distension. Transpiratory pressure is very important. I show you that has to be carefully recorded and interpreted. Mechanical power is another parameter to be considered. Of course, it requires more research, but at least allows us to have a full view of the ventilatory setting and especially respiratory rate. The alveolar recruitment might be assessed at the bedside even by mechanical parameters, and so not only by lung imaging, which may be, of course, used together. Gas exchange, there are different ways. Just to mention here, don't look only at the oxygenation, but also at the CO2 side in terms of dead space or surrogates. Lung imaging from CT scan, which is not always useful, but lung ultrasound and AT might be more and more used in the next future. Phenotypes are very interesting, but of course we have to learn more about that. And remember, we have to put together physiology and clinical practice together, maintaining the right balance between both sides. Thank you very much.
Thank you, Dr. Pelosi, for this overview of all these parameters that we should apply in protective ventilation. Any questions from the floor? Just a very quick one from me, Paolo. Do you think there is a specific subset of patients that is susceptible to damage inflicted by the ventilator, or are all patients equally susceptible? Because we are in this session on personalized medicine, right?
I think that more the lung is affected, as it was shown, more the lung. So if you apply the same ventilator-induced lung injury in a more affected or less affected lung, the worst effect are in the worst lung. But we know now that also non-RDS patients, even in anesthesia, should be the lung should be ventilated very gently. Of course, the parameters, the threshold might differ. I show you a sort of example through mechanical power, but we know now that, for example, a plateau pressure higher than 20, 22, even in anesthesia, which is the more healthy lung that we know, might have some effects postoperatively. And in non-RDS patients that we consider not so relevant from the point of view of ventilator-induced injury, we know now that also non-RDS patients might have quite high mortality, 35% higher than we expected. And so the lung should be always gently ventilated, independent from...
Everybody's susceptible. Thanks again. Okay, we move on to the last speaker of this session. I'd like to introduce Dr. Ashley de B. Decker, who will talk to us about clinical decision support mechanisms.
Thank you, and good morning to everyone. I'm completely aware that what I've learned just a couple of half an hour ago or something like that, after this marathon of presentations, our indirect calorimetry measurements and ultrasound of the muscles will be devastating probably. So you're all hungry, but therefore I hope to present you a light talk about clinical decision support systems, on where we are now, and maybe even more importantly, if you want to create them or you want to buy one, to give you some good tips and tricks on what to watch for if you decide to do it. And I want to bring you back on a bit more than a century ago with where Luc Fidel painted the doctor, and as you can see, it was pretty easy for us back then. We didn't have many diagnostic or treatment options, so the only thing we could do is sit at the bedside. But with all the knowledge we gained in this century, we found out that we built hospital within hospitals. We have so many specialists involved in our patient, and also physiotherapists and that, all of them, that it's pretty hard for us to get a good overview of our patients. And as a result, we have a very large growth of data now. And for us at the bedside, and especially in critical care, where we need to sometimes make decisions in very stressful moments, it's very hard for us to get a quick overview on who is this patient, what does he want, what are the most important data on which I would need to reflect my decisions. And the data is still growing. And in critical care, we need to look at the life-threatening disease, but also all these other elements that should be controlled to prevent complications. And maybe clinical decision support systems, so technology, can help us to advise what we should decide in these complex decision-making moments. And as the data is growing, well, these systems and these algorithms can learn from it more easily and provide us better advices. And I want to begin with the most important thing of clinical decision support system is the definition, because it intends to improve healthcare delivery by enhancing personalized medical decisions. That's why we are here in this session, at the point of care. And I think this is the most important one for critical care, because this is the most difficult one. How can we present these advices to our critical care deliverers at the point of care? Because that's very difficult in stressful moments. And it should all be based on targeted clinical knowledge, so the current guidelines and evidence-based medicine, patient information, which is in the EMR, but also in the monitoring, and all these raw data wave patterns that passes, and other health information. And basically, the architecture of this system is quite similar to what we are doing. We start with data input. We acquire data from the guidelines, from the patient, from the monitor. We analyze this, and based on our knowledge, we make a decision, and we take action. And CDS systems work in the same kind of way. And the architecture is based on two types of systems. One is you get the data input, and you have an engine that is showing transparent, evidence-based decision trees and algorithms, so you know exactly how it is choosing which advice based on the measurements and data you've got. And you've got non-knowledge-based system, which is a very big hype currently, in which artificial intelligence and machine learning models are determining which advice we see or output we get. But the difficulty in this, and we are talking about our patients who are very in critical conditions and vulnerable, is that we as a clinician at the bedside, we want to know where is this advice coming from before we implement it. So what I thought was interesting when I did my thesis about this subject is to have a look on how much of our scientific interest is going to each of these areas. And if you look it up in PubMed and Google, you will find tons of data and journals and articles about the data analysis part. So a lot of groups are busy with algorithms, artificial intelligence, machine learning models to provide us very good algorithms to make our decisions. And that's okay, but we also need to look at this area, and this is an area which has a moderate kind of interest because we've learned from the algorithms that if our data input is garbage, there will be also garbage coming out of it. So we need to acquire our data more better in a certain way. And with natural language processing, because a lot of our data is still around 60–70% is still non-structured data. Natural language processing is an interesting theory and model that might improve this acquiring data area. But what I didn't expect but found out was that the level of interest for the data output on what we see at the bedside, at which moment and how we need to control these advices is very low in scientific interest. So how do we present these solutions to our clinicians at the bedside? And this is the most difficult part, I think, because we can make, as we've seen in all the sessions here before, I can increase my data input with more than 100 options, data options. But if I make for neuro, for the feeding, for ventilation, all kind of new clinical decision support systems, besides my EMR, which is exploding at this moment, well, my work at the patient bedside will be impossible if I get all these advices at the same time, and especially in stressful moments. So we need to find out a method to bring all these advices in the future that we get from very smart algorithms and very good input back to the clinician at the bedside. And if we look at clinical decision support system, there are basically three types. You can define and say different types are information management tools, so that are our EMRs, so store and grant access to medical data. But as you probably know in your field and in the daily practice, we are overwhelmed at this moment by the number of data we get, and especially if you consider that phenotypes and genetics are coming in. We've got tools for focusing attention, such as pop-up alerts due to potential drug harms, because the system sees what the kidney function is and how much we are giving from a certain medicine. And we've got tools that provide patient-tailored advice, and that's what we think is the most interesting one, because it's giving us diagnostic and treatment assistance. And although CDS systems are there since the 1970s, with the exploding data growth, we see that more and more CDS systems are developed. And we are also getting more insights in what the structure should be in developing these systems. And this is kind of similar on creating new medication or vaccines. That's a big hype now. But there are crucial differences that needs to be highlighted in this state. And that's because we have the same stages, so it's stage 1, stage 2, stage 3, and stage 4 after the market release. And we look at safety and efficacy and pilot. But what is kind of different with medication is that we don't make one kind of medication and try out different dosages, but we need to realize that we make these systems and we need to refine them and redesign them as we go on the whole. Because if we don't do that, you will take a long time before you have your market release, and then you have to sell the product. And at the moment you sell the product, there's our new products coming in. So you need to be flexible in it. And in this development and validation phases, I think and I believe it's as important to do quantitative research, but also to do qualitative research, because we need to know from our end users and also the patients, who are also the end users, on how these systems work on our daily practice. Do they fit into the daily workflow? Can we use them? Are they hampering us or not? And that will explain also the outcomes from the quantitative research. So this is a very busy dia, but what I want to show you is some elements that can help you decide on when you want to choose for a CDS system, on which points you need to have interest. And I want to highlight 4 out of it. And to start with it is you have to anticipate if the CDS system does what it needs to do to anticipate your user's need. So is the user a patient, or is it your nurse at the bedside? Is it the doctor? And does the system do what it needs to do? And that can be of an advantage for the patient, better outcomes in mortality or in length of stay, but it can also be an advantage for the medical staff, making your work as a medical staff, as a nurse, as a doctor more easy and giving you better trust. Another very important one is system interoperability. If you buy a CDS system that doesn't cooperate with your EMR, it will probably lose in daily practice. So you need to know if there's a connection between it. And in the future, where ventilator and all these raw data information will be more important for our algorithms, it will be also very interesting to see if all these systems can talk with each other. Unfortunately, all these systems are of different companies. So I think we as clinicians need to say to these companies that they have to think about how we make the interoperability between all those systems much better, and so the data also between the systems can be transported to each other, and to have the best outcome from our new algorithms that we are making. You need also to think of system transparency, what I talked about before. If the algorithms are based on AI or machine learning, it will be kind of black boxes for your nurses and physicians to work with. And if your staff isn't able to do that or doesn't want to learn from it, it will be very hard to introduce your system in your practice. And of course, and it's a bit on what I just said, you need organizational support. And that's, I think, the most important one. And what we've learned in Eindhoven, where there's now BrainPort and a connection between ASML, Philips, the hospitals, and the university, we make ecosystems that get the finance there. And then we try to get all the parties at the same table. So end users, patient, and medical staff, and those are the most important ones because they tell you what the needs are, but also the companies, researchers, and the engineers, because we need to know what the limits are of our current technology and what to expect if we get black boxes back, and if we are able to accept that or not. And from that view, I think we can make much better CDS systems, because currently we are reading a lot about it, but how much we are using it in our daily practice is very low for the technology advanced part of history we are at now. And just to show you how important it is that we work together and we sit at the same table very occasionally, is an illustrative anecdote to close my presentation. If we look at a CT scan as medical staff or medical intellect, and we want to build a 3D modeled personalized external aortic root support, so kind of stand at the external part, we look from the downside to the liver. So the liver is on the left, but for our engineers, they look always from the upside to the drawings. So what happened when they tried to make such a stent is that they made it all the way the wrong way, so to the right instead of the left. And by sitting together, we see what the opportunities we've got in how we can say to each other, no, you're looking at it wrongly, because if we look at CT scan, we look at it differently. And we only can learn that from each other if we talk to each other, because we don't have engineers in our medical universities. So I want to thank you all for your attention, and we can go to lunch then, I think, if you are okay with it.
We have time for a question.
First of all, a very, very nice presentation, very clear and extremely important. We face a crisis, at least in my country, the United States, where our personnel do not understand physiology, and they're making all their decisions based on physiological outcomes, like blood pressure's falling, or heart rate is going up, or whatever. Any system to help these people must repair two things. One, put tools in the armamentarium of people that we train. You know, physiology has been down-regulated in recent years as we learn about molecular biology and statistical methods in the center. All very important. The most important thing at the bedside is physiology. Then our support system must be reactive, because what a doctor does at the bedside, I'm not preaching here, this is what it seems to me after 40 years, is we make an integrated decision, maybe helped by a decision support system, but not very often in my practice. And then we observe the result and react to that. And if we don't react on the basis of what is really true and in our tool belt, that we understand the physiology, and the physiology of the particular problem we're dealing with, we can't possibly predict the outcome for any given individual except within a broad range. So any system has to be reactive. That's my major point.
Yeah. So I completely agree, and I also see that, and that's also one of the elements that are that you need to take with you when you're deciding for a clinical decision is to make it or to buy it, is that there needs a kind of educational form in it, so that you learn on what the advice is, how to interpret it, and maybe bring in physiology. That's what would be very interesting. But you also have all these things to bring in personalized medicine, so for feeding, hemodynamics, ventilation. It will be pretty tough to do this in one single system. So we still have to learn, and to give you a small feedback. If you look at automated ventilation, for example, what you see is the nurse is looking at the system. What is the system doing with my patient? And from there, they are starting to think again, why does the system do this? Why is the FiO2 going up? And they are bringing back their physiology part from their education to understand. So sometimes also clinical decision support systems, and especially if you get this closed format that they do things at their own, can help the staff at the bedside to learn from it. But still, we are the final responsibles ones, and we need to learn the most of it. We need to know the most of it. So I completely agree.
Any other questions? We have a couple of minutes. Some of our speakers are still here. Dr. Douglas, Dr. Pelosi are still here. If there are any questions for them, I'm not sure if Dr. Taccone is still here. If not, we'll conclude this morning. I want to thank my... oh, please, I'm sorry.
Yeah, very good question, and if I understand correctly, if we use apps and that kind of stuff to
the fire standard in this one on fire standard.
Okay, so the standardized methods to make data transportable and interoperable. Is that what you asked?
For clinical decisions purposes.
Yeah.
Using the smart standard for doing, is that the right direction? These proprietary systems are
I think it's a beginning, because it doesn't fit all. And that's what we've seen a lot on diagnostic and treatment bringing together to bill, for example. So we see that there are many patients, and especially if you go to personalized medicine, where you get all those phenotypes, probably we won't be able to fit it all in all kinds of boxes to transport the data and translate it to other systems to use a standardized method. So my opinion, as we are getting more smart and smarter, and I believe in the raw data material. So just get the raw data and let our engineers work with these data instead of making already certain decisions for it and putting it in boxes and transport all those boxes to other systems. I hope this is a good answer for your question.
Okay, other questions for any of our speakers this morning? Okay, in the absence of those, I'd like to thank my co-moderator, the audiovisual staff. Thank you all for attending this session, and look forward to seeing you after lunch.